else? So again, they don't have minimal numbers yet. They will soon. Like, for residency, you need to do the 15 vaginal hysterectomy. To 15, so they don't say you have to do 10 CVSs or 50 CVSs before you graduate. They will soon but for many other reasons, it's good for you to do it. Also, we show our numbers, and obviously if we have like CVSs, I think is the better one. But if we have 50 CVSs and you show you've done 3, it also is like, what kind of fellowship program are you, and if we've done 15,000 ultrasounds and you say 0, like, are they,
Yeah, we know that's not true. Like, yeah, we know.
Yeah. But so we actually did apply. We did press the button and applied for a CGME third fellow. We don't know what's going to happen. There are many steps, internal and external, but we did apply. And one of the things that, no fault of anyone, probably mostly us, I'll take it on me, like there are 5 main criteria, for increase in numbers. Like, you guys have passed your boards, there are no citations, you guys are doing well, thesis and research, etc. But the one thing, procedure, like, some of the fellows, in the last couple of years put in 0 for ultrasound. And, if they believe that, there's no way, we're going to get that. And, we just don't want that to happen in the future because it's not, we told them that you guys do it and stuff, but, they in general believe the fellows a lot more than us, which they probably should anyway. But it doesn't reflect well on you.
And it might change in the future. So we just want to get in the practice of doing it. So that if you, there is a minimum, that's not a problem.
Yeah.
So.
Also I think Dr. Roman requested I make a shared critical care list. So I've shared it with you guys.
Yeah. That'd be great.
Yeah, that's good to log those.
They ask us our numbers of critical care, also, in general for the whole thing. And we got these numbers for Abington, for Nemours, for Einstein. And they also ask our numbers of hysterectomy or, that kind of thing. That's it. Just want to let you know that.
Yeah, and if you have any questions, like, again, I personally don't log them, but I'm happy to reach out to other programs, like, for tips. I know, like, you've logged a bunch, so perhaps you have some knowledge to share.
In terms of, like, I would go back and see.
Yeah.
This was ultrasounds or ultrasounds read, correct?
No, ultrasound performed and or read.
So
and or read.
So sorry, I was just gonna say, like, the number is 0, but then this last page, again, I didn't print all 390 pages, but this was Keely's report from, like, the whatever the ultrasound software was. Yeah, AS, exactly. Yeah. She downloaded that. So I was like, Keely did like 1,500, like, over her 3 years that,
And growth ultrasound doesn't count, right? Just like a detailed anatomy. But I don't think you have to.
No, detailed anatomy should be the 20-week. Or sometimes, if she's late for care, 30, but detailed anatomy. That Doppler, usually, FGR, echo, obvious. So it's pretty, that's the obvious. And again, the issue is 0, and there's going to be variations. I know some of you are going to do, 40 CVSs and some are going to do 10 or whatever, but
yeah.
Anything else?
Did we talk about next week is SIM?
We did talk about it.
Okay, just as a reminder, there's a for grand round / teaching next week. Or I don't know if it's grand rounds or other, but
I think it's a grand rounds too.
Yeah. So but it's
like
going to be
from the person from Reading.
Yeah. So we're not going to have our usual meeting because it'll be the SIM, and then you guys have fellow wellness that day, right? Kavisha, am I getting weeks wrong?
Yeah. It's a fifth.
Yeah. So so if there is important clinical cases for review, I would just bring that up separately, either in our group chat or with specific attendings, to make sure you have plans of care as needed, because we won't be able to do our usual clinical meeting. following, the SIM, it's the CCC meeting, and so which you fellows aren't a part of. So you guys just would do the SIM and then your wellness, and then back in the afternoon for regular clinical care.
Thanks, Eric.
Yeah, thank you.
Speaking of which, can I make an announcement? We have a new MFM board examiner.
Yay.
I mean, that's a great achievement. I said many, but that's a really super happy, well deserved. You do great. It's a great experience, and it's good for all of us, to have somebody who is there, sees what's going on, and see what's new. You won't be able to talk to her now for the next few years. No. But seriously, it's a huge honor. Any other announcements? You guys
I'm
wanna
just
make?
gonna pass this to
thank
the
you.
fellows. This is just Brandy's who gave it to me to have the delegation logs. So she just wants all the fellows to sign it. I'm just starting it off, so first name, last name, signature, and initials.
So that's important sort of in perpetuity, for any research study that you may be involved in, that involves patient consent. So like for Paxis or Latch or whatever, it just has the log there of your signature, so that if someone wants to go back and compare who's consenting patients, to make sure that the right person, is doing whatever, that's what it's for. So it's just kind of regulatory documentation that's needed for human subjects research, and to make things easier for you guys, we just have you sign one delegation log and then copy and paste that to specific study delegation logs as applicable.
In terms of the meeting after, actually Grand Round was really good, and OBCC, and we'll do the case review. Then I guess you're going over some verbs and controversial discussions. Then we have in the presentation, the template, and then the precious trial at 11:45. Anything else? Otherwise, the question of the day is, complete the sentence. I've never in my life been so angry as when.
Never.
But never angry.
I mean, I feel like I'm angry a lot, but it happens quickly. It's part of my high emotional state. I don't know. I think feelings like happiness and love linger longer than anger. So it's hard for me to think of a time that I was like insanely angry. Probably something related to politics that I shouldn't talk about. Maybe it happens more frequently than I admit.
For me, I mean, I guess in terms of, maybe similar emotion, but despair. I remember I was in, so I went to study abroad in undergrad in India, Brazil, and South Africa. And I was doing the summer before that, like a internship in India, and needed to get my Brazil visa in order to go on the study abroad trip for the fall. And so I had to bring my passport to the Brazilian embassy in India to get it done. And I remember I dropped it off a month before, like something very early on, and they still hadn't processed my visa, and I needed to go back to the US the next day to go back to back home. And I was like, oh my God, I'm not gonna go on the study abroad program. I'm gonna just not be able to do this amazing study abroad, and I'm gonna or I'm gonna be stuck in India and not be able to go home. And then I remember calling the Brazilian embassy and being really angry with them. And then I was like, this has been here for a month, you haven't done anything about it. And then they like ended up just doing it the same day and I picked up my passport. But then, and then they were like, we need your mother's like social security or like birth certificate or something. And I was like, oh my God, I don't have that. And I had to like call my dad and then like, he literally emailed it over and then I got it. I got my visa, but it was very stressful. And I remember being very like in despair.
Actually, I don't get angry that much. At least I try not to get angry that much. But I agree, maybe political rights that in Italy sometimes are missing. Things like that for me are very important. That's what get me more angry than everything else.
I think I've been more disappointed than angry. I tested positive for COVID right day before I was supposed to leave for my sister's bridal shower. The Omicron variant canceled a trip to Kenya that I had been planning for like a year when my husband was working there for a couple months. We were gonna go like do something together before he started working. That was very disappointing. But we went somewhere else and it was lovely. So we had a good time out of it.
Actually, for me, it's really difficult to find an exact moment because being angry is a baseline emotion when I'm in Italy. If I have to find, but if I have to find an exact moment, a recent moment is when Trump recently changed the visa stuff about H1B, yes, visa. That made me really angry. But in general, it's difficult for me to identify this moment. Yes.
For me, it was a time that I struck my little toe, kind of like put the side of the bed. I got really angry because it hurt a lot. But then I tried to tough it out. One day later, I had to go to the ED. I had a broken toe. So that made me really mad. I was embarrassed. Like I got a broken toe from like striking the bed. And every time I will tell the doctor in the ED, they're like, are you sure? I'm like, I'm sure. And it was actually broken. I had to be with a specialist for 2 to 3 weeks. So again, it was kind of like an anger. But then I was angry the whole 2 weeks, just annoyed that happened.
I cannot remember the last time I was angry. I think I have like transient irritations that's short-lived. But now that I started doing Botox, I can't get irritated. So I can't not be irritated, and then I just get irritated.
Across the street.
Yeah, is it expensive?
It's $11-12, right, per
That's
unit?
bad.
Yeah, because of being a deaf person. Yeah.
Oh, come on.
Anger line here.
I can't wait.
I know, see, it's like once you start.
I'm waiting for my tax return.
Oh, come
Which is in April, no, in April. Really wait. Oh, me, yeah, sorry. Like literally 2 days ago, because my loans were increased in my payment because of I was on the save plan and then went all of that insane things. So now I had to like fight with my loan officers. I'm trying to do public forgiveness. So then there's that. And the amount that they increased is now like so insane that I was essentially like deprived. Anyways, it's very unfair. It's very unjust. I think the things that make me upset are things that are unfair and unjust. Whether it happens to me or happens to the people I love, that's what I get. Which unfortunately lately has been occurring a lot. Anyways.
So for me, I think anger and hurt kind of goes hand in hand for me. Like Eileen and Dr. Bolig, a lot of political things are making me really sad right now and also angry. But the last time I remember being really angry, this might be oversharing, but my dad struggles with drinking and kind of hit rock bottom a little bit earlier this year. And I'm so sorry. And in trying to like figure out like what rehab programs are in the Caribbean, like there's nothing that exists that is free or covered. And it's like I was so upset that like there are a lot of people who need help and you have to, they call it like rehab for the elites, and that just made me like really angry. So yeah, sorry, I didn't think I would cry.
No, that's important. Thanks for sharing. Yeah. Good luck with that. Major issue. Not fair. Makes us all angry. Angry. Yeah, so, you know me, well, that I think I get angry when like you guys are all converters, but when I have sometimes a new Asian person or a new intern or a medical student who says, there's nothing published on this. And it's it's one of those things that I should count to 10 and 20. But I feel it inside, and it's not to the person, it's to the institution and to their mentors and stuff. And it's a frame of mind that not everybody has. And I can tell then, during the week of service or whatever interactions downstairs, there was changes, but I feel it inside. It's almost like a visceral thing. I feel so strong about it. And it's interesting, with time, some of those things don't get better. But I control it as much as I can. And I think I thank all of you because I don't get angry, because you guys, I drank the Kool-Aid, so to speak, and are with the program. What about online? So yeah, what about you? What you think?
I think rather than getting angry, I think I experience frustration a lot. I think similar to some other people throughout the day, I experience frustration a lot of the times, but it usually will just blow off. Political things have been making me very frustrated recently. And then something on a more funny note, a couple days ago, I have a very small like upholstery cleaner, and I decided I wanted to clean my entire stairway. So I had a whole tank of dirty water, and when I went to remove it to dump it in the toilet, it just spilled all over my carpet again. So that was a moment.
That does not go well with discipline. Yeah.
Yeah, so that was fun.
And who is next there? Melissa and/or Stephanie? Are you guys connected?
Hi, we're here. Melissa told me I have to go first. If you know me, I try my best not to get angry, because I'm one of those angry criers, and I don't like that. Um, but I feel like the last time I was truly angry was in May. One of the things that really sets me off is feeling disrespected and unappreciated. And that was the last time I really kind of felt that way. But other than that, I have a low, you know, irritation that's always rumbling in me in the midst of like happiness. So it was probably May. Melissa, you have to go now.
Thanks.
Yes, good morning. I feel like I don't really get angry like other people said. I mean, I definitely get irritated and annoyed, but real anger, I can't think of the last time I like felt that like raging anger. So yeah, not I don't have an example.
And Emily Oliver, good morning. Are you there? You are?
Hi.
Did he request you? Were you following?
What's that? Yeah. What's the last thing that made you angry? Is that right?
Yeah.
So again, I'm irritable at baseline, I think, but I think that the true anger, I think I share with a lot of people here, are all the political things that are happening right now. And I think taking a break, every other day or maybe for a week or so could be good to help with that. But that's really the thing that makes me angry. Otherwise, not really.
I'm sorry, things that have like political.
Political, yeah.
Yeah.
I just want to clarify, Like, I get angry. I think there are people who don't get angry and are very like positive, happy people. I get angry daily. I get over it daily. I want it to come off like I'm that kind of saint. I'm not. I definitely get angry a lot, and I have to remind myself not to speak or react because I know that I'll be over it, and it's probably a much smaller deal than I think it is in my head.
And for example, at the leadership meeting, I wasn't expecting those questions, but they counted to 10, they're coming out of the room. For example, sometimes I get disappointed with the 3-year-old, not pooping his diapers, but that's not anger, but then you think about that's perfectly normal behavior, the same way that normal behavior is. I think there's nothing on this, and you just were taught not to look up things and stuff. So I think that helps me a lot to kind of, calm down. We can work on this, we can fight. There are things that are harder to fight. And some of you brought them up. But you can still somehow, be more for change. Great, thanks for sharing. Do we start with the inpatient?
To start with the inpatient list, we have first Karen. She's a 17-year-old G1P0, 24 and 6, presented with a history of dysuria since Sunday and came in with nausea, vomiting, and back pain. On admission, she was found to have a temperature of 100.3 and was kind of like very febrile and was a little bit lethargic. So at that time,
100.3 or 100?
103.
Okay.
And because of that presentation and very high temperature, we started her on broad spectrum antibiotics with vancomycin and zosyn, and we ordered CBC, CMP, urine cultures, and blood cultures. At that time, she also referred that she was having shortness of breath, so chest X-ray was ordered for that. So going into her kind of like her problems for her suspected pyelonephritis, and she met STIRS criteria when she first came in. She received the vancomycin overnight, but she had a reaction to it. It seems like it was more a lot of itching and a lot of redness. So pharmacy said probably because of the vancomycin was infused too fast, but in the setting that it might be an allergic reaction, let's de-escalate and then do the ceftriaxone. So she's currently on ceftriaxone from that. From her Tmax, she has been afebrile since the first time that she was here, 103. Other than that, she has been completely afebrile. She's currently getting the Tylenol, that the 1 gram. She got 2 boluses when she first came in, and she's currently at 125 cc's for fluids. We're still pending her renal ultrasound because her UA came back with positive blood, positive looks and nitrates, and we're waiting for the blood cultures and renal cultures. She was negative for COVID and flu in the setting of the shortness of breath, but we ordered the chest X-ray that was currently being scheduled. She has been starting overnight, 95 to 99, mostly in the 98 to 99. She was found to have an iron deficiency anemia with a hemoglobin of 9.8. This pregnancy had a normal anatomy and normal EFW for baby. So plan for her for today would be to review the imaging when it's back, and hopefully she continues to be afebrile, and in the next 24 hours we can consider transitioning to PO, which is stable and afebrile. Our next patient, it's Hazel. She's a 38-year-old G2P1001. She is currently post-op day 2 after a low transfer C-section in the setting of preterm labor. She also had a Mirena IUD. She was here admitted in the setting of MMT and just went into preterm labor and the admission. For her postpartum,
Who's 20?
She was 28 and
28.
she was
5.
28 and 5 at that time.
She had her anatomy scan, like because she was in and out of the hospital, she never got like a formal anatomy scan and like cervical things, so it was done in the hospital. And I think, I don't know if she had declined her anatomy, like her cervical length or whatever, but yeah.
It's interesting. She was never had abdominal pain complaints for what, 5 days a week.
Yeah,
She's
yeah.
been stabilized, was 200 plus, and then
Yeah.
methadone, and then
She was actually gonna go home. She was gonna
overnight.
go to.
Yeah, she's gonna go home the next day, yeah. Yeah.
So from a postpartum standpoint, she is doing well. It's been a little bit hard to get her pain under control given her methadone use too. So we're moving and changing a little bit of her regimen. And if she's still having pain today, the next step would be just to consult acute pain to see how they can support us in on controlling her pain as best as possible. From her
Did
MN
she have a like stat under general or regional?
Yeah,
To do a tap?
I don't think so.
Usually not if it happens overnight.
Yeah. It was overnight.
Yeah.
Yeah.
It's not something to do that.
For her MMT, she is currently on 260 today. She had to get one dose this morning. Her CAL scores have been pretty low, 3 and 2, so it's hard to know if this is pain from surgery, kind of like versus just withdrawal symptoms. But she's getting better, and seems like we're getting her a little bit more stable. She would continue in inpatient management, and she already has accepted to my sister's place, and they're okay whenever baby comes. If kind of like she's 28 weeks, but they are okay with baby coming too. In terms of her, she had some elevated blood pressures back on the 26th. There were only 2 and 1 yesterday. Her labs have been completely normal. In the setting of just her withdrawal and acute pain, we're not calling her anything. We're just following up and seeing if she meets criteria for anything. But right now we're just holding up. And she has been stable, no signs and symptoms of preeclampsia. I think that's the main things for her. For the next patient, she is Hart. She's a 23-year-old G4P0121. She's a 34 and 4. She is currently on hospital day 4. She initially came in with abdominal pain, contraction, and preterm labor. She made change when she came in, she was 2 centimeters and she remained the same, but in the setting of history of preterm delivery and 2 centimeters, she was giving beta, and she's beta complete now. In the last 2 days, she has been complaining of this abdominal pain that comes and goes. It's worse during the night. She has been checked multiple times and she has been the same. She also yesterday complained on some vaginal kind of like bleeding, maybe vaginal. She was checked and that was unremarkable, no bleeding. And then she thought that maybe it was coming maybe from constipation. So from that standpoint, baby has been looking okay. Overnight, she was able to sleep all night and did not need any pain medication for her contractions. So we'll just see what she's doing today in terms of her contractions and see if we think that she can go or want to discharge her. In the setting of this persistent abdominal pain, and she was having like some back-to-back contractions, and she not fed all of them, we did some abruption labs that they came with our normal limits. But that was kind of like one of our suspicions, but it labs are normal at this moment and no vaginal bleeding.
What abruption labs do you like?
So for her, we did a CBC and then we did a fibrinogen.
Story is very similar to eclampsia.
Yeah, exactly. I'm
And,
thinking
you know,
deja vu.
And it's like similar in the sense that like somebody presenting for this pain does have low volume, like amplitude, kind of uterine irritability, like urine culture negative, like no signs of infection anywhere else. Like she reported some pain with like wiping, but she thought it was in the setting of like also straining. And when I did her spec, there was like nothing. So something is happening, but we just like are not catching it. And then I think she herself is just frustrated because we were gonna send her home like yesterday and like, you know, telling her all these things, and she just feels like, why am I still having this pain then? You know, if I'm still the
How many
same.
weeks is she?
She's 34 and 4. Yeah. She was the patient who was admitted a few weeks ago with like ongoing contractions. Again, was like ruled out for preterm labor, but then started to have some pain spotting, and then was discharged, I think once.
Twice.
Twice. And then kept on coming back, and then also maybe like a few days later did progress to labor, and then and then presumably abruption around.
Yeah, I think you can't preclude an occult abruption. You can't diagnose it on ultrasound. Her labs are like rock solid, so if there's a it might be something small, but it's not something substantial.
Yeah, yeah. So it's just like trying to have.
Does she want to go home, or does she want to stay? I think we'll never be able to eliminate her pain. Like if it's a chronic abruption or preterm labor without cervical change, neither of those are things that we can treat.
Yeah. Well, yesterday, we had a counselor it was better to go home, etc. But then then she herself was just frustrated with the entire lack of diagnosis which was like, well, if you're not doing anything here, I want to go home.
Right.
And then her partner, who was like sitting there all upset, came out and chatted with us and was like, look, I think it might be better, for her to stay another day for monitoring, and then we can kind of reassess.
Right.
So
okay, we'll kind of see where her headspace is at. I also, I think we've all had cases like this, where it eventually it declares itself, and sometimes it involves a discharge and return a week later, and sometimes it's a few days later. I think if she's having persistent pain and isn't comfortable going home, I'm fine with keeping her and giving TID NSTs until one of us gets tired of it.
Yeah.
But
well, we had made a plan for close to
and what's her pregnancy history?
She has a history of a preterm birth at 32 weeks.
And cervical length this time? I know she's over 34 weeks.
Oh, she actually didn't ever have an anatomy.
So
like on a presentation.
labor.
Oh, she's 2 centimeters dilated.
She's 2 centimeters dilated.
Oh, that's
She also presented to Einstein September with some blood place, and they did a temperature for the point that is 2 centimeters, lengthwise.
Oh, okay.
I don't think we did a.
No, when she's 2 centimeters dilated.
Yeah.
Or guideline, whatever algorithm says, 3 or more, even go to the
She's also over 34.
less than 3, yeah. But she's surely at risk, if she was 20 those,
Yeah.
years ago.
And preterm birth.
Yeah, this is something that hopefully some of you will discover. Obviously, we need more research. Years ago, like decades ago, people used to do thesis, check the thing. Like I would imagine that it could be that their fluid could be bloody. Certainly, the IL-6 should probably another one of the markers maybe high. But then what do you do with that? That's just a lot back in the day, but we don't really have a medication to treat it or an IL-6 high enough to say it's safer to deliver. But surely, something is going on that we need more.
And that's for
Research, more data.
No, inflammation,
inflammation, IL-6 is inflammation.
Something triggered
because if there is cervix, some bacteria may invade. Maybe she doesn't have actual bacteria, but maybe the corium is infected and or be infected and inflamed, and so it's just a pathway, to inflammatory infection. It started, and that's why which is feeling a little bit under the hospital.
Our next patient, Chelsea, she's a 31-year-old, she's 7P1323. She's 33 and 4. She came in with complaint of kind of vaginal fluid since Saturday, but she came in on the 18th. She came into the 21st, but she seems to be leaking since the 18th. She had a history indicators or clash in place and was found to be under hypertension, and it was removed, and she was 150-2, and rupture was confirmed at that time. She was started on latency antibiotics and was given betamethasone for that. She has been rechecked with the SPEC exam, and she looks maybe 1 to 2 centimeters dilated. She has this leukocytosis of 12.5, again, probably in the setting of reactivity because of the betamethasone. She doesn't have any signs and symptoms of choreo, and her vital signs have remained stable. She also has anxiety and depression currently on no medications. Yesterday, she was a little bit frustrated and was wanting to leave. We were able to talk about her, but she desires a 34-week delivery, and we talk about risk and benefits, and that's the plan, and we're really coordinated that for her.
We had discussed expectant management versus until 37 weeks, which I wasn't as familiar with. And we were looking into some of the studies about like vaginitis swabs, and she had a positive BV like a few weeks ago and then was treated. And because she was treated, we didn't re-swab her. And so that kind of makes the question of whether or not she's even eligible for second management until
What
37.
was your final?
Well,
Is this for
ended up
discussion or?
swabbed her. I don't
Did
know.
or did not?
We did. but
Yeah, I talked with Moti
Yeah.
about it. So
Yeah.
the study, you know, based on the randomized study, those pauses were done on a mission for PPROM. Well, the BV was done, like you say, earlier or something like that.
It wasn't like if in your pregnancy you ever had a vaginitis.
Right.
Yes.
On
Yeah.
admission. You had
Yeah. And again, it's a subgroup analysis, smaller numbers. So I think what you did is fine. And, if she's negative, you could sort of.
Moti said that she didn't want her.
No, regardless.
But once we
She
deliver.
wants to be delivered at
34
34 weeks regardless due to like
Easy.
social reasons, et cetera. But it was just like an interesting.
discussion. Yeah.
Yeah.
That took months of analyzing the data, because each randomized study did a different, vaginitis thing, and then part of it's a yeast, is really like, yeast and group prep and chlamydia, they're all together and you can sub-analyze them.
Right.
And so I'm sure there is more to study again there as well.
And to clarify, it's not like a general culture, right? It's like, primary chlamydia, BV.
Some did some cultures, some did some other cultures, 3 randomized studies, IPD data, and some did more, some studied less. A little bit heterogeneous.
Yeah.
But, the subgroup analysis that came up with the idea was just somebody else. When we looked at that, then the one that had somehow something, sort of anything, again, it could be yeast, could be strep, anything, they were the worst if you didn't expect them.
For our next patient, Peterson, she's a 39-year-old G3P2 011. She's 24 and 6 today. She's admitted for MMT and hand wounds. She was just transferred from St. Mary's. This is currently her hospital day 5. So I'm gonna just go by problems, so she's pretty complicated. For her MMT, she's currently on 130 with CAL scores of 3, 4, 3, and 13. So hopefully we can get her a little bit more stable in that. We have scheduled multiple medications. She seems to be very groggy in the mornings, but feels a little bit better during the day. She has this history of type 2 diabetes. Her last A1C was a month ago and was 14. When she was here, she was last discharged on a regimen of 32 units of Lantus at night and 12 with every meal. It seems like she was not compliant with this outpatient. And when she first came in, her blood pressures were in the high 200s. Her beta hydroxylate was within normal limits, and given her uncontrolled blood glucoses, we tried to increase her Lantus to 36, but then she started having low, so we just kept it at 32 where she was. For her blood glucoses, it has been a little bit challenging to control. She is eating. It seems like for her, she gets her preprandial and it's normal, but then her postprandial, that it's 2 hours after eating, are in the lows. Yesterday or overnight, her post dinner was 46. She was symptomatic with that, and she only got 10 units with that Lispro. And she's eating a lot, and she's snacking a lot. After that came up with some snacks to 122, but then 1 hour later came down to 54. So very labile blood glucoses. And in the setting that she was living in the 200 and prior admission 400, anything I think less than 100 would be kind of like an impact from her body. We decreased the Lispro to 8 and kept the Lantus at 32. But we just have to see exactly what she's doing. It seems like, I don't know if
So she was admitted like when Dr. Bola got on service a couple weeks ago.
Yeah.
And so she had never been on any insulin during this pregnancy, and given her A1C was like 14, we started her on this like weight-based regimen, and then her sugars were still high upon discharge in the last mission, but we just kept it that. Unfortunately, she was admitted, I think a couple.
She never followed up.
Yeah, she never followed up. She never took any of her medications. She and then was readmitted for withdrawal. And then, upon admission, glucose has remained elevated, like 100s. So we put her back on the same regimen that we discharged her with. But now, like, she's been eating a ton, like all day, like every day. And yet her sugars are like 50, 60, 70. It's just like a weird.
It's a little early for her placenta. to
Yeah.
grow.
I know, that's what I was thinking about, but she's not, but the growth was normal also. So what we mean is like, as your, you know, sometimes your insulin resistance gets better because your placental health gets worse.
Yeah.
And so there's been studies looking at changes in HPL and its association with like placentally mediated adverse outcomes. You can have, if you have a decline in your HPL, results in decline in your insulin resistance that's associated with fetal growth restriction and preeclampsia. And we had a recent patient with that, with severe preeclampsia and terrible diabetes,
But typically doesn't happen at 20.
not typically.
Not without like already other evidence of placental insufficiency.
Yeah.
That's also weird.
And we're certain that the insulin she's getting is being given at the appropriate time in relation to her eating.
So yes, but the long acting, the nurses, so the first stage, the long acting was not given like the first night, but she was very high. So we said just give it in the morning and we kept it in the morning. But this has confused the nurses. So the long acting, sometimes they wait until she's 10 or 12 to give it. But again, it's long acting, but the short acting it has been given like as appropriate.
Well, she takes like 3 to 4 hours to eat her meal, like if that makes sense.
Yeah.
So because she'll sleep or like she'll like nod off as she's eating and then she'll like get back into
Also, I
eating.
wonder if it's part of the issue, right? If they're giving it to her before she starts eating, or like, you know, because ideally, right, we give rapid acting insulin about 10 to 15 minutes before you start eating. I don't know what they're doing on 11p, but if they are doing that and then she's like taking a single bite and then nodding off,
And
that would drop her.
Should we, the other thing is we could focus on just long acting and just take away the meal time, especially just for her and her ability to adhere to a regimen. And we could do BID long acting.
Would this be someone in addition to the long acting that you'd consider metformin too?
Yeah, if the long acting is not enough, you can to improve or reduce her insulin requirement. But it seems like if we take away the mealtime, it's not, I mean, she's going low, just like stop it. And units is not a lot.
We also had this chronic hand wounds that were called cellulitis on her prior, when she was on St. Mary's. It seems like her lactate was pretty high and they thought that that was kind of like the why her hand. So she was started on like clindamycin, vancomycin on the other hospital, and we continued it here. She was initially refusing labs, so IG got to get involved to see what we're gonna do with her bank if we're not able to get the levels. So IG recommended to start her on daptomycin and ceftriaxone, and she's currently on that. The plan for her is probably to continue IV and transition to PO. Her hand seems to be very chronic. They are dry, they are crusted. It doesn't seem like she has an active cellulitis at this moment. And her white blood cell count is currently 12, which is reassuring. Her blood cultures from the outside hospital were able to call and were negative. She has a history of chronic hypertension. She did not use any medications on this pregnancy. On her past admission, she was having normal to mild ranges, but in this admission, her blood pressures have been pretty high. She did have a UTOX that was positive in St. Mary's for cocaine, but when she first came in here, cocaine was not found. But her blood pressures have been in the 160s, non-sustained. Sometimes we have to treat her because of sustained blood pressures. Her lab work have remained stable, and she has been feeling okay with no signs of preeclampsia. We have been up-titrating her nifedipine. She was on nifedipine 30, then nifedipine 60, but overnight her blood pressures were spiking up. So we did BID dose in 60 and 30, but she had again 160s overnight. So we have to see. And the conversation has been, is this the cocaine? Is this part of the withdrawal? Is this worsening chronic hypertension, or this is more of a preeclampsia history? She has a history of HELP with an IUFG at 37 weeks. So it's a very kind of like murky picture because multiple things are happening at the same time. But this is a change in baseline when you look back at the
date for cocaine.
Let me see if I can give you a specific.
A week prior to.
Yeah, when she was,
or no, maybe
It was in
a
St.
day or-
Mary's, probably
a day
2 or 3
prior,
days
yeah.
before she came in.
Yeah,
Which is what?
so now that.
I can check to see exactly which
She's
day.
been here for.
It's been-
Yeah, she's been here for, yeah, more than a week probably.
Did we repeat a year in UDS?
On admission, but not, we have not repeated again.
It was positive at St. Mary's, but negative.
No, yeah, I'm just thinking like timing wise, it's a little, so cocaine, so I've definitely seen lingering sort of elevated blood pressure with cocaine. Like for a week, but it's a little weird for it to be not elevated and then a week later get elevated.
Yeah. I think right now, like I am, well, she has this history of chronic hypertension. We started on the medications. We were trying to see, is this superimposed COPD preeclampsia? So, cause she had the last admission, her, the urine UC was 0.4. Then on the mission, we repeated a UC of 1.07. So we did a 24-hour urine. And it came back as 204.
Yeah, a UPC
Yeah.
for someone who's dehydrated or not well nourished is not gonna be as reliable.
Yeah. I mean, what about the 24?
The 24-hour, so I think, so I wouldn't worry about the UPC, I think the 24 hours. That is
Yeah. And then the labs have been, I mean, initially we were having some issues getting labs from her,
Yeah.
but they've been.
That's probably.
Yeah. So.
Anything that's too many things for her.
And just, yeah. The 37 weeks if she makes it.
Yeah.
Cause she had
To that.
like a bedside scan inpatient, or at least.
Yesterday, eliminating anatomy. Everything grossly that we saw looked normal. The growth was 22nd percentile.
677 grams.
Yeah, 677 grams. We did not do Dopplers, but yeah.
For the next patient, this is a post-op patient, type 2 diabetes. For her diabetes, she has been doing well. Her A1C last was 6. And we are just doing a lunches 22 at night, and she has been responding well. CDI with meals. She only received 2 units yesterday, meeting all postpartum milestones and fresh today. Yeah, she is a 37-year-old G3P2002, 38 and 6. She is currently post-op day 1 after a C-section. The C-section in itself was uncomplicated, and this pregnancy was uncomplicated, but she does have a history of an amniotic fluid embolism in her first pregnancy that required ECMO, but it was a failed ECMO, and then she had to get a thrombectomy, sternotomy because of some thrombi in the chest. So that's why she is currently on our service. She is currently doing well. Her blood pressures have been doing fine. She's currently on Lovenox, and she will
Delivered,
C-section.
scheduled,
C-section. Yeah.
38 days. Oh, right. She was the one here.
She followed her pregnancy in Ohio, but then came here to for delivery.
Second or third,
Third, she had her.
We had one
before.
before. Yeah.
You had a tubal.
She had a tubal.
And then.
IVF pregnancy. Right. Yeah. She's doing well currently on Lovenox, and the plan is for her to continue on the Lovenox for 6 weeks. And then the last patient of our list is just more of an FYI patient. 43-year-old GAP3226. She's 14 and 3, admitted to the psychiatric for SI. She's doing well, no OB complaints. It's an FYI.
The lady with the AFE doing prophylactic Lovenox is just out of an abundance of caution because of her.
Yeah, it's not related to the AFE. Is
I
that?
think it's because of the thrombus that she had on the chest that she had to get a sternotomy.
Got it, but the thrombus was related to failed ECMO.
Yeah.
Okay, got it. So we're just being like abundantly cautious. Okay, just was making sure I wasn't missing something related to an AFE. I need for regulation in the future. At least, okay.
Anything else about inpatient? Any old patients or anything?
There's
To discharge or?
there was one patient from last week, Samantha Timmons, who was sent in from Jefferson, Washington Township. sorry, but so she is a 4-year-old G8P2143. She was at 30 and 2 and admitted from a transfer of care after presenting with nausea and vomiting at Washington Township, and was found to be hyperglycemic, ketones in her urine, BDPA. So in that setting, she was stabilized over there. Interestingly, they did like sub-Q insulin for management of her DKA.
They don't have
Okay. But the reason why she was transferred to us is because baby has a CPAM with the low CBR was like 0.75, yeah. But the neonatologist there didn't feel comfortable managing her if they were to feel her for whatever reason. So she was transferred here. She was also at the time like hypertensive, history of chronic hypertension, and so they were trying to rule her out for superimposed severe preeclampsia. When she got here, she was still hyperglycemic, so we started her on insulin drip. Interestingly, her like anion gap was never elevated. She did have an elevated beta hydroxybutyrate, so we ended up putting on her insulin drip and then bridged her to long acting. And then her blood pressure is normalized when she came here, so we did not think it was superimposed. Yeah. And then she was doing well upon discharge. It was just like a matter of coordination with like trying to get her to appointments because she doesn't have transportation, and so she relies on motive care to get to all appointments. And if they don't show up, she just doesn't attend appointments. So we're just trying to like arrange for appointments in New Jersey for her.
I spent a long time talking to Jess, Carol, and Lee, and Star, who are the schedulers at Jersey, the front desk staff, when you guys were discharging her to make sure that her follow-up visits were appropriately scheduled. I know that there was a lot of frustration with getting her scheduled because they would call the patient and the patient would be like, can you call me back because I'm eating? Can you call me back because like I like need to go to the bathroom?
Yeah.
So she's also someone who's like hard to engage in care even when you try to engage her in care. I guess my question well, she's on the high risk list in Jersey, obviously, is the NICU there ever going to be comfortable taking care of her baby? Because if they are not, then we need to figure out an alternative place for her to deliver here.
When I talked with the person who called for the transfer,
Yeah.
they get the impression that the neonatologist wouldn't be comfortable at any point. And so that's why I talked to her, like, you should have your ultrasounds and whatever at Jersey where it's easier, given transportation issues and stuff. But maybe you should have, a couple of visits downtown so that people know you if you're going to deliver downtown. That may not be right, let the phone call.
Yeah.
That's the impression they gave me.
Okay, all right.
They will never be comfortable.
Got it. I mean, I'm not super surprised by that. NICU is not a high level NICU.
Even if it's,
Low CBR and she's term. Yeah.
Yeah.
Okay, no problem.
So that's what we should,
So
if that's the case, we should have, a visit or two with Larry with somebody
Yeah, I can figure
down
that out.
here.
Yeah,
Yeah.
hopefully we can.
Or a clinic, whatever.
Yeah. Hopefully transportation.
Yeah, and hopefully she can make it.
Has she like been able to get her diabetes or like? Is this the patient I'm thinking was like no social?
Correct. She has
Yeah,
like no,
nothing.
nothing.
She's
has
not
No.
like here for prenatal appointments.
She can't get transport here. I know.
Yeah, that's what I mean. Like she, no,
If we
I'm
arrange it, she will come, obviously.
well, no, the transport is the transportation. She would be.
Won't drive her across state.
Yeah. Or will not.
I don't think so.
No, exactly, not for
Okay,
prenatal
better.
care, because prenatal care is something she can get in for.
Hi, sorry. I was actually just on the
Thank you.
I'd actually just muted you guys because I was just on the phone to this patient.
Yeah.
But basically it was just scheduled as a telehealth, but she scheduled her NSTs and follow-up.
Here,
And
I mean, at Jersey.
Yeah.
we'll see if she actually can get here. I'll talk to her. I just put her on hold for a second because I saw you guys were talking about her. I think her diabetes still has like it's
Yeah, it's terrible.
terrible. So I was gonna recommend a 37-week delivery for her because I think her risk
Yeah.
of stillbirth is pretty high. The issue that we had last week when she was here is that neonatology said that they weren't comfortable with her delivering here. The CPAM is actually smaller than it was before. So I was going to try and talk to them because I just don't think like she's going to keep presenting here. So
Right.
Emily, I'll send a secure chat today and include you and the NICU team so that we
yeah, I
can.
don't know who I should talk to there, but I just think it would be worth a conversation because it's very small and the CVR is like so.
That would be the best
Yeah, I just don't think
action
I don't.
plan,
Yeah.
if possible.
Yeah, ideally, yeah.
And then Dr. Alcohol, just wanted me to present this patient who's not an inpatient, but Jacqueline, 40-year-old prime, 39.4. I think she's a Weiss Center patient. Because I presented the AD PKD lecture, she like saw that patient same day with renal cyst, history of renal cyst since 2010, and then immediately
The mom has renal cyst.
the mom has renal cyst, and this was dug up in like the part of, not even noted on like her routine renal care. And so she was referred to nephrology, and they did genetic testing, and she was positive for a mutation in the PKD1 gene. And so, and that she just sent that message to me yesterday, and so she's 39 weeks. I think there might be some issues getting outpatient imaging, so we're just gonna plan on getting like renal imaging for her. She's here inpatient for. Yeah.
No, when I was, just for the sake of talking, forgive me, Eileen, I missed some of your fetal therapy, and so if you talked about this, I'm sorry. When I was a fellow, we used to talk always about, if somebody had autosomal dominant polycystic kidney disease, should we be imaging their brain for Berry aneurysms? And, the general like guidelines from what I can tell now, but please correct me if somebody else feels differently, is that unless there's a family history of intracranial manifestation, so, mom with a prior intracranial aneurysm or a family history of sudden death that was unexplained, we don't necessarily need to be working all these patients up for Berry aneurysms before they come in for their delivery. But I feel like when I was a fellow, I ordered MRIs on all of these people. So that's like a newer thing that I learned in the last couple of months.
Yeah, I think that's confirmed in the guidelines now, so.
You
have
another patient that has polycystic that's already diagnosed, and we're working on getting her an MRI. I'm sorry, she has a family history of like 2 people with
that a
a
different one?
aneurysm.
Oh, yeah, that's right.
Yeah.
Sounds reasonable.
Yeah, exactly.
Oh, this is a different patient.
There's a different patient, yeah, she's first trimester.
Okay, because the one I'm thinking of is third trimester, the one I've seen before. Not this one.
Okay. No, she's like first trimester.
Okay, then there's 3 of them.
Yeah, great.
Oh, yeah, I think I might have presented that patient for the field therapy. This is a separate one, but. I think that's inpatient.
Thank you both. Thank you for your presentation. Any outpatients or?
Did we just, before you go through new skins, did we talk about the patient with the C-spine hemivertebrae and delivery planning?
The one that had the negative MRI?
Yeah, but on ultrasound, we still see like this little angulation on the
There were
C-spine.
messages about it, but I don't think we came to a conclusion.
Yeah, and, okay,
We didn't get a chance to bring her up last time.
Okay.
Yeah. Fetal therapy, I can bring her up.
Yeah.
Today, yeah, so let me.
Yeah, can we go over her now, because I might have to leave to do a consult shortly, so.
Okay, so this is Miss McGonigal.
Let's do Ruch's first. Yeah.
So,
Sorry, just because in case you-
yeah, I think I'm just waiting for them to let me know where I need to go. So this is a patient, I think she had been previously reviewed a while ago from her, and I think there was concern for a hemivertebrae and C-spine. And she had an MRI which appeared normal. I couldn't actually find anything on sensitivity of MRI. So as far as hemivertebrae goes, most commonly Huda did a review on this, which was very helpful. It's most commonly lumbar or thoracic. It's like I couldn't find any cases of an isolated C-spine hemivertebra. And it can be associated with adverse perinatal outcomes, generally because it's associated with other anomalies, but in isolation tends to have a good prognosis. Hemivertebrae by itself is not an indication for a cesarean delivery. And in looking at diagnosis of hemivertebrae, from my review of the literature, it was all based on ultrasound. I couldn't find anything on MRI being better, more sensitive or not compared to ultrasound. So she had this concern, you know, she had like that kind of angulation that on the C-spine that was concerning for hemivertebrae. She had an MRI that appeared normal. On her ultrasound since then, you still see that like area of angulation. So, you know, whether it's a true hemivertebrae or not, it's unclear. But the question, Hood and I were reviewing, just talking about her case, and one thing that came up is whether it would affect delivery cleaning, because obviously you're having flexion of your neck at the time of a vaginal delivery. You also flex the neck at the time of delivery, you know, C-section. Those are both things that happen. But whether you would think like, do you want to try to avoid an operative delivery? I think like, for example, an outlet delivery, kind of already at that flex neck point, that doesn't matter. But is this someone that you want to do like a +2 operative delivery on or not? And again, I could not find anything about C-spine hemivertebrae in isolation and delivery mode. There's in like the literature review when there was a C-spine hemi, or there was like a pregnancy termination because it was associated with all these other things. So I didn't know if people had thoughts about whether we should make any kind of delivery recommendation. She has a prior section and strongly desires to TOLAC. She had a vaginal delivery of a section, terrible post-op recovery experience from a section, really doesn't want to have C-section. So whether we should say anything at all, and just say routine care, or say avoid like high operative delivery, or you know, avoid. I don't think we need to say avoid operative delivery at all. Again, because if those parts are down its outlet, that would be the best way to deliver the baby. But yeah,
I think his work is MFM. I was looking at things with mine as well.
they don't say anything about it.
Well,
sorry, they say vaginal delivery.
some say, yeah.
I couldn't find any
Technical indication.
obstetrical, usual indication. Yeah, so on and Fetal Medicine Foundation also says no impact on delivery.
Yeah.
So just don't say anything.
So yeah.
Yeah, okay.
Technical indication. Yeah, that's what I would.
Okay. That's good. That's all.
Yeah.
Yes, sorry, my.
AS is doing the things. It's been really, for those of you who haven't been in scans recently, it's been good.
EAS is running really slow.
I had a triplet echo last week that took me like 3 hours to look at all the pictures. Yeah.
Same with the MFM Clinical Fetal Medicine Foundation. They say it's some further indication.
Yep, so okay, thank you.
Okay, so while waiting for this to load, this is Ms. McConnell. She presented to us yesterday for an anatomy ultrasound. She's a 30-year-old G5P3 vaginal delivery before. She's at 24 and 6, dated by LMP. She had late to prenatal care to our family medicine colleagues just established 2 weeks ago. Prior to that, she didn't have any prenatal scan or genetic testing. Her past medical history is significant for obesity, status post bariatric surgery about 3-4 years back, and polysubstance use recently established with the methadone clinic. So as we're going through the scans, you can see it's very quick for us to appreciate that baby has severe anomalies. So as Shannon scanned through the head, you can see right here abnormal structure. And on a sagittal view, seeing here, you know, I don't know if you want me to dictate or.
Do it. Yeah, up to you.
Or if like you want. like,
Oh,
the
no, I
facts,
would love,
so-
I would love for the first, I think some of these are so obvious, for lack of a better word, that, yeah, maybe Lachey and Eileen can comment on what they're seeing or not seeing. So if that's supposed to be a sagittal view of the brain,
There's no.
there's no,
Like just one,
It's like, is it a
like enlarged.
encephalocele or?
there's, so the brain tissue looks like it's exposed. Are you seeing any cranium? Any clear cranium? Yeah, so there's an anencephaly. I don't wanna break AS, but see if you can skip to clip 39, because, and then we'll go on to whatever else she has, cause the hardest anomaly to find is the second one, right? But so she has anencephaly, and she has some other things.
And it's loading.
It's loading.
Yes, is breaking us. We're breaking.
I know.
AS is breaking us, that's true. Maybe it's right before that, in 38. Sorry, I just want, like, I think that coronal clip is so impressive. This is the worst anomaly I've ever seen. Like, this is the most things I've ever seen in one single live baby. 24. Nope, maybe it's 41, sorry.
Those are pretty.
All right, just, yeah, we'll just keep going, sorry, Ann. I wanna be able to see the clip, yeah.
Yeah, so here you can see large abdominal wall defects with the whole entire liver, you know, outside of the body here. So we have brain anomalies, we have abdominal wall defects with most of the viscera outside of the body. And then when you're looking transfers into the thorax, we're also seeing the tip of the heart, you know, is outside of the body or ectopic cordis. So here again, this liver and some bowels there, unable to really appreciate the stomach or the bladder. And as we go, here you can start to see when we start going up into the face, we also saw bilateral cleft lip and palate. So now we're having, you know, major midline defects starting at the, you know, the cranium, the face, the abdominal, and then the thorax. We're slowly appreciating these bands that are coming into view. Right. Extensively here, more bands here. And I think at 60 something makes more. Yeah.
So when if you're keep going in, but if you're seeing this, right, you're seeing a large abdominal wall defect, you're seeing a massive anencephaly. There's also, we might not see it, but there's clubbing of the feet. So multiple different like anomalies in multiple different organ systems. And then there's a bilateral cleft lip. You should start to think about amniotic band sequence, even if you don't see amniotic bands. In her case, we actually can see the bands, like you can visualize the wisps in the amniotic cavity, so it made it even easier. But you know, that should be high on your differential when there's this many different sort of reduction anomalies is the exact right word, but sort of structural abnormalities that don't fit with another clinical picture.
And you know, we did a quick attempt at biometry. Babies, you know, understandably hard to really do a biometry, but it's about 450 grams. We had a just extensive discussion with her, you know, giving lethal anomalies in multiple compartment and the bands that we saw on ultrasound. We're concerned for amniotic band syndrome. It's sporadic, rare. And you know, we offer her termination. Other option can also be considered is continuing pregnancy. We understand the risks of IUFD, possibly mice. She opted to terminate the pregnancy, so we're in the process of getting her set up with New Jersey clinic colleagues. We approached a conversation with her about genetic, counseling. We did tell her that, the amniotic band syndrome obviously does not have genetic components underlying.
So, we followed up with her to see if she's interested in doing more testing. But at this time, understandably, difficult news.
When AS is work, so that's a great picture. See how all those bands are sort of attached to the fetus? And so when you scan, like, in live time, Shannon was basically like, you can see the bands like it's like a web that the fetus is trapped in. Yeah. Yeah.
Was the fetus moving or was a bit?
I don't know, actually. I didn't scan her myself. Body was moving.
How early is that? Like, is it from early?
Early, like, so unfortunately, this would have been caught at her NT scan if she'd had an NT scan.
But it's, I would have canceled, this is lethal. And definitely, liver out with no membranes around it. Survivor.
Yeah, in some ways, well, obviously this was a difficult counseling session for everyone, when it's a lethal, like clearly a lethal anomaly, it's actually a little bit easier, right? This is a lethal anomaly. You can continue the pregnancy and the baby will die, or you can terminate the pregnancy. Makes not to be that cut and dry. Obviously, there's a lot of empathy involved in those discussions, but it's a little bit easier than the like nuanced discussions of like neonatal repair, etc.
Regarding, the group consensus on placenta accreta at this station.
So I'll tell you about this patient because Jen was in echo yesterday when I scanned her. She has 2 prior sections. She has a known anterior previa. She was 29 weeks when I scanned her yesterday. We've seen her before, and she has previously had small placental lakes, but it wasn't felt that she, despite her high a priori risk of accreta, that there was really enough evidence there to be convincing for accreta. Yesterday was the first time that I had scanned her, so I'm just curious to get additional opinions about what other people are thinking, because so this is all abdominally. She does have, lakes throughout. There's a little bit of bulging sort of at the like upper part of the bladder there, where you can see that the uterine contour is a little bit unusual. And then we did a vaginal scan as well once AS is ready.
Version. Is this like not just
It's not just us. No, it's unfortunate. Well, I don't know if it's not just, it's all of us here in Center City, but I don't know if it's AS everywhere because Jersey was working fine on Monday. So this is it vaginally, and so you can still see that sort of like bulging towards the bladder. I couldn't see any bridging vessels that clearly like crossed the placenta into the bladder, and there's definitely some myometrial tissue, but I was pretty concerned in looking at this, and I wanted to, given that she's 29 weeks, I wanted to get other people's
lakes alone.
Yeah, are very sensitive. Yeah.
She had a scan prior to this.
We've scanned her before. Yeah.
She's just 2 prior sections.
The 2 prior sections. So, her a priori risk is 40%. So I talked to her yesterday that just to cut to the chase, and I wanted to obviously get your all's thoughts, that I was concerned based on the appearance that this looked more like an accreta than we had previously talked with her about. We talked about the implications of an accreta. We talked about, timing of delivery, possible C-hist, possible need for a blood transfusion. I scheduled her for a MFM consult because she actually hasn't seen us in the office. She's a health center patient. And then I scheduled to bring her back for another vaginal scan in 3 weeks when she's 32 and change, so that we can make a firm plan for her delivery. But I think we should treat her as an accreta. Obviously, if her placenta comes out, that's great, but I am worried it will not. And it's sort of like, this is from 25 weeks. It's not like, obviously the placenta's grown, but the degree of like bulging that we were seeing yesterday is a lot more impressive now than it was then. And that just also like makes me worry that the placenta's growing out, Yeah.
I agree.
Okay, great.
Yeah, interesting. I think the good thing is there's no cervical invasion, which is good.
Yeah.
I didn't
Yeah,
see
it doesn't look like it's
hypovascular
going into the
cervix.
cervix.
But it's right there.
Yeah, but I agree with you. Like this placenta looks huge. It looks pretty thick. Some lacunae, little bit hypovascular. So I think we have enough criteria to manage her as you did, Whitney. And thank you so much for bringing this to everybody's attention.
Great. So she's coming to. It is, exactly. She's coming to a MFM clinic near you for consult, but I prepped her for all the things yesterday. She's only speaks Spanish. I don't know, and I should look at after our discussion with OBCC today, because she's a health center patient. I don't know what her most recent hemoglobin is, but maybe I should, or Sophie or Yen, maybe we could ask Steph or Melissa to look her up and send us her most recent hemoglobin so that if it is low, we can start initiating IV iron things before we even see her for her consult.
I'll put her in the OBCC list.
Thank you.
She's in the last one.
Yeah, I think this is such an important point, really, the IV iron therapy. And I really think like anytime a patient we diagnose her with like low-lying placenta or even, certainly placenta previa at 20 weeks, I wish like, we can't be doing everything in scans, but I really wish that we optimize. So now I'm putting in my reports for every low-lying placenta previa at 20 weeks, please optimize hemoglobin hematocrit. And if I have time and I see that, sometimes you look and 13 has already been done and it's like 15. I'm like, please send her for IV iron therapy or do iron studies if they haven't been done and hemoglobin is 10. So I think, there's so much we could do ourselves basically in scans. Yeah.
She's literally not a single in her.
I know, that's what I mean. She's only seen at the health center and in scans, like we've never seen her. So I say, please get her MFM consult ASAP.
Yeah. And we can always text Jill. She really responds. We can talk to the same day.
Consult next week.
Yeah, I think next week is fine. Great. Thank you.
Thank you.
I have one more scan to discuss. This is a patient that Dr. Alfatli and I saw on Monday. Okay. So briefly, she's a 31-year-old G5P2, 2 vaginal delivery before, no history of C-section, but did have a history of DNC early last year for this baby. Last time we saw her around 20 weeks at anatomy. We noticed that she has a very complex placental architecture that we continue to appreciate today. Let me zoom in. So last time what we saw was filamentous cord insertion that measure 4.7 from the internal os. What we saw a few days ago was very similar. Also, we measured that insertion was about 3 centimeters from the internal os. So we think that she has filamentous cord insertion with vasa previa. I'm going to go through since this is just faster than doing this. What we also saw is she had this interesting. So we continue to see this cord after inserting into the placenta here. There's a cord that traverses across the lower uterine segment and insert almost maybe into like a thin subcentral lobe in the anterior wall of the uterus. Although like when Simone scanned over there, we're unable to see it. Like where is it implanting into the anterior wall? But regardless, we saw that the vessels is near this os here. Thoughts is this could be like a type 2, but also why do we see it inserting one side of the placenta, posterior placenta, but then also inserting into the anterior wall with a lobe that we cannot visualize definitively. We have thoughts on. So here you can see it again. Posterior placenta. This cord, we saw it in her anatomy ultrasound as well. It's like traverse and then just fix into the anterior wall. I don't know if it's stuck there before we go to the baby or what. That's so strange. So
It could be that there's two, it could be a furcate placenta where there's two insertions and one is filamentous.
Okay. FURCAT.
Yeah, it's called a furcate placenta. But it's normally it's like two into the placenta. I've never seen one where it's into the membrane.
To the membrane, but it does happen. I think that's a type 3 vasoprevia.
But you're saying there's two insertions, is that right?
That's what we seem to
Yeah.
see.
So
It's very
yeah.
almost like fixed here in the anterior wall that we continue to see, after 3 weeks. But when we, scan over that area, the most we can think is we most likely a very thin placenta lobe.
Or it's just inserting into the membranes anteriorly, inserting into the placenta posteriorly and trace it along anteriorly.
We could not.
But you can trace it over the cervix going into the anterior wall.
Yes, we can trace it very well in the posterior wall, but we just not quite sure what's going on here. So at this time, she has a MFM consults in 2 weeks. We already have extensive discussion with her. We present for filamentous with vasoprevia, and depending on her next scan, would treat accordingly. For her history, she no procedures.
It's a DNC.
Except for the development and the
Not us. This is spontaneous pregnancy.
just spontaneous.
Yeah, this typically looks for IVF pregnancies.
Yeah.
Very, very interesting case. Simone did a beautiful drawing, but then again, Kavisha, I saw this patient with you like 3 weeks ago, and
I
we did
remember.
a report, cannot rule out vasoprevia. So we scanned her, me and Yen, and basically,
This posterior, this is her anterior wall.
so basically, yeah. But this is all in the lower uterine segment. So I think this will have clinical implications, if we're doing a C-section. It's
That's what it looks to me as well. Let's share as Sandy, maybe you actually want to share your screen. Because it does look like to me it would make sense there are two lobes there, and that's what Howard is doing, and she found an article, so
yeah, great.
are you not connected, right?
Yeah. So this vasoprevia vesicle is very lateral, so that everybody know, but the cord insertion is pretty anterior midline. So which is like very short, really, from like 3 centimeters from the cervix, which we would be cutting for the C-section. So great, thanks, Lishay.
Any
Vera, can you let Leshay?
so any recommendations on the next time she comes in? Any further view that we should try to elicit further?
Let's talk about this real quick because it's gonna help us. Maybe you can share the article, but that image that she was showing seems to be, and it's called a
Looks like a locate umbilical cord insertion.
bilobe placenta, which I think is what.
We just can't see that anterior placenta.
Yeah, you can't see it as well, but if it's inserting, it must be inserting in some kind of maybe thin placenta or something. See, even here in this picture, it's not that clear that the ends it's inserting somewhere, but it must be inserting eventually, maybe in a filamentous way, in a substantive way.
Or it's just inserting filamentous and traveling back to us. Like either way.
The problem with these placentas is that the cord insertions don't have, I mean, it's filamentous, but they don't have Wharton's jelly. So sometimes you see it split like perfectly in two, but there's no Wharton's jelly there. So there's a risk that can rupture. And there's some cases there's not good, that there's lots of case reports about it.
This is the vasoprevia. No.
This is another.
What happened to the Hopkins one? Did she have vaginal
Free.
What could you see anything on the? No, it's just like a thrombosed vessel, right?
Oh, the other update, Natalie Rodriguez, our A flutter patient, also delivered
Oh.
on Monday.
Did she ever convert?
No.
Section.
She had a repeat section. I did a quick ultrasound before and still an A flutter.
What was her gestational age at
She was 37 and now. Her baseline, you know how it had decreased and then went back up on Monday.
Oh, really?
But it wasn't to the point where because I think when we had asked on that interdisciplinary meeting, what is the goal? And we said anywhere between 180 to 200.
Yeah.
And so that she was in that range, but regardless, she had a uncomplicated C-section. The baby was part of it very once. I saw her yesterday, baby was in the room.
Yeah, I mean, I think we just were unable to treat her. Did she, and she, I don't know, I was wondering if we had just started with Sotalol, because the patient herself became very reluctant to continue to add therapies. And so, picking a not as effective therapy to start with.
Yeah.
Set us up for failure.
It was actually a great multi-7 service, and even the question of site of delivery, and Margaret was there and she was very comfortable saying that deliver here. There were a lot of cardiologists on. What I liked is that the patient knew that there was a chance that it would resolve. I guess it didn't, but everybody said it's one and done. You cardio convert once, which is exactly what.
So I was gonna say, we've talked about this on service when I've had these patients, and I know Yen talked about this when she did her fetal therapy, but fetal A-flutter, right, isn't something that persists after birth, right? You treat it and it's over versus fetal SVT, which is a more significant problem.
Very grateful.
No, that's great. Yeah. Well, it was certainly a lot of people.
Yeah. And she was enrolled in cases.
I'm gonna bring up quickly, one of you can handle the parvovirus.
Yeah, that parvovirus patient that presented at the end of September with symptoms to triage, she had her IgM and IgG both positive. Obtained in triage, and then we kind of discussed she was amenable to amnio, and we were doing weekly high drops until that resulted, and her parvo was negative on amnio.
About 3 weeks.
3 weeks
later.
Exactly after she became symptomatic, and I guess a little over 2 weeks after her titers were also positive. She's already seroconverted. The amnio was negative. We were going to stop doing high drops checks, which have been normal so far. Does anybody?
And you could say more than that.
Yeah.
Like you looked at literature.
Yeah. I let's bring it up.
How many weeks ago was the
So the amnio to parvo was 3 weeks.
But now, how far out is she from parvo?
She's still within 12 weeks.
Oh, okay.
She's 6 weeks out. So if we continued, it would be the entire remainder of the pregnancy for 12 weeks.
But we would have expected, I assume,
we
would have expected to have seen it in the AMDS.
Yes, on the limited literature that exists, they saw it on 3 weeks after exposure, and they did not do it. Obviously, there's not a ton of. I can send around the papers.
Yeah, we both looked, and basically, as 30% chance of fetal infection, if you have a full infection, that usually manifests. The viremia manifests
within
right away. So you can never be 100%. Like she says, Sophie, limited information, but seem to be reassuring that the baby should have been positive.
She has an LGA fetus, so she's coming for another growth in 2 weeks anyway. It's a bad appointment, and that'll be. I think that's 34 weeks for her. Mary's medicine.
Yeah, she didn't come yesterday, but which is, I figured let her piece of everything.
It literally had just resulted
Yeah.
like an hour before we saw her. And she was. Is anybody who was just stopping?
No, I think we usually don't have an amnio, which is why we
Right.
continue.
Yeah.
Which is
Yeah.
great that.
Yeah.
And she's never had anything borderline, which is, sometimes we've continued when, like, watch it, like they got worse, like got better, we cracked it out.
You were writing, the evidence-based chapters for fifth edition, and I make an amendment to that chapter because, we say fetal diagnosis is made by PCR, by amnio PCR, but we really won't say who to test, when to
Yeah.
test, what to do with the test result, which is again, still up for debate, but I
The thing
think,
is that the sensitivity of an amnio.
yeah, it's.
At this
timeline.
Yeah, yeah.
And you've done you think that guideline is based on the fact that most people aren't getting amnios, and so we just are doing a default because you don't know.
Yeah. Great. Any other cases, ultrasound or office hours or anything? We move to noise.
Sure. Share my other. We did this literature search like a year or two ago, but essentially the question was, patient presents to the office or triage with decreased fetal movement. Oh, sorry. Yeah, and the fly books. Is there, a role for obtaining a growth ultrasound, like other than just sending for an NST, like after 28 weeks, like, should we do an ultrasound? And so just as like, I'll go over like a quick summary and then put just more specific details about the studies a little bit later. But systematic reviews have showed that like decreased fetal movement has been associated with adverse pregnancy outcomes, including like a 3.4 higher odds of stillbirth, as well as a 1.3 higher odds of SGA. These are non-randomized studies. And multiple cohort studies have shown that 9 to up to 17% of pregnancies presenting greater than 28 weeks gestation with decreased fetal movement have SGA infants. There was one QI study that implemented just like a standardized protocol for, instructing patients about kick counts and then, how to manage decreased fetal movement if identified. And they found an overall 33% reduction in stillbirths, as well as an 83% improvement in FGR detection. So from like 2.4 to 1.4%. And then, there was a recent article by Turner et al. Who did a case control study and found no difference in abnormal ultrasound findings. So UA Dopplers, MCA Dopplers, cerebral placental ratio, EFWS and 10 percentile or MVP between decreased fetal movement patients versus controls, but they did notice that those with recurrent decreased fetal movement had more abnormal final scans. Regardless, there was no difference in clinical outcomes between the two groups. And they calculated that the number needed to scan was 48 to detect one new case of SGA.
Does it also say the gestational age of the decreased fetal movement?
Greater than 28.
Okay.
How they define
28
it.
weeks,
Yeah,
thanks.
yeah.
Yeah, I was wondering about that.
Yeah. And so interestingly, ACOG does not have a guideline on management of decreased movement, but RCOG, which is UK guidelines, they recommend clinical assessment plus a fundal height, plus or minus a growth ultrasound for all patients presenting with decreased movement greater than 28 weeks. And then especially consider the growth ultrasound if they have persistent decreased movement, additional risk factors, as we know. And they write that it should be performed within 24 hours, if indicated, which is interesting. And then again, like between 24 and 28 weeks, there's less evidence on how to manage these cases, but for archive, you confirm heart tones, there's no evidence to recommend NST, and then we can consider ultrasound, but there's again, no evidence at that gestational age. And interestingly, there's no randomized control trials of, outcomes of women with decreased fetal movement who receive ultrasound scan versus not. And so, I went, which is like a number of sentences about each study, going into specific details, but a lot of the studies looked at SGA and not, which is like small for gestational age, like at the time that the baby's born, but not necessarily FGR, fetal growth restriction, which we care about on ultrasound. So that I think that's like a slight nuance. I highlighted all the results for SGA in red and then FGR in purple. I mentioned the systematic review of non-randomized studies. And then, let's see, this study was a cohort study that, of about 100,000 women presenting a decreased fetal movement. And they had a clear clinical pathway for these patients. So funnel height, NST, fetal-maternal hemorrhage test, and then plus or minus an ultrasound. And they did not find a higher odds of stillbirth, though this was significant for those with 2 or more presentations of they did find an association with SGA. It was an adjusted odds ratio of 1.14. And then, the odds of more SGA were higher among those who presented greater than 20 weeks, but less than 32 weeks. Women without decreased. Yeah, no. Yeah. Zoom in a little bit more.
You're making me so happy going back to what we discussed this morning. This is something that I think a lot of people say, well, we don't know. Look how much evidence there is. I mean, it may not be the best, but you found so many articles.
Yeah.
Love it. Thank you, Vincenzo, for echoing my feelings.
Yeah.
In terms of FGR, there was a cohort study that found that, again, there was an increased rate of FGR among those presenting with increased fetal movement. It was like a rate of like 9.5%. And then when they adjusted for these factors, again, it was significant. And then this retrospective study again looked at 200 patients presenting triage with decreased fetal movement. 25% of infants were FGA, and then 72 of those were not.
Wait, sorry, just to go back to
Yeah,
Dutton. So when
sure.
it was adjusted for baseline differences, just the
Yeah.
weight was slightly lower, but there wasn't
Correct.
actually a higher rate of SGA.
Let me see. There was a higher rate of SGA.
No, over here. Oh. It says when adjusted. So is this an adjusted or?
So SGA is probably
an
not
adjusted.
adjusted.
An adjusted. So when it's adjusted,
Fetal weight.
only estimated fetal weight was
Significant.
lower, which was.
I'm not sure they looked at SGA.
Yeah, just because, I mean, that's kind of an important
Yeah, yeah.
distinction, right? Like many things will have baseline differences in people with and without a presentation, so the adjusted odds ratio is usually what you would.
Keep on going.
Yeah, it's yeah.
I'll look back into the.
I was gonna just ask, for some of these retrospective studies that look at SGA only, I'm assuming they didn't have an ultrasound to be able to look for EFW, but we're assuming that some of them would have been FGR since many of them are SGA.
Yes, exactly. Yeah, I think that's what I think because the ultrasound.
Yeah,
exactly.
which is actually
Right, which is, yeah.
I think that's the issue with some of the studies is that there's no definitive guideline for ultrasound, getting an ultrasound or not, and so that's why I think that is a little bit more.
But actually reduced bias, right? Because everyone's gonna have a birth weight, but if you look at people who do have an ultrasound versus people who don't, obviously you're gonna have a higher detection rate of something if you're looking for it.
Yourself to do an ultrasound.
Yeah.
Again, these studies are similar data, about SGA specifically. Yeah, this one showed that of the 200 patients presenting to triage with decreased fetal movement, 25% of the SGA, 72 of the SGA infants were not identified by fundal height or ultrasound measurement of fetal growth prior to presenting with SGA. And then they're still more likely to be measuring small for dates, so a ratio of 21. So that's pretty, it's pretty convincing.
Eileen, can you go back to Sullivan?
Yeah.
Hold on. So Sullivan had an adjusted odds ratio of almost 22.
Yeah, I mean, these numbers are all over the
measuring
place.
Sullivan. Yeah, it is. It is.
Yeah, exactly.
I think that
Seems like somebody needs to.
let me just go.
Yeah.
This study.
Go ahead. Yeah.
Yeah, go to the most recent. That's also a long time.
This
Go
is
ahead.
2023.
No, the other one, 2009 or something.
Yeah, I think because of the heterogeneity of the studies and kind of unclear guidance of what to do these patients. This was a study done in AJOG MFM a couple years ago that compared rates, as I mentioned earlier, of abnormal ultrasound findings. So specifically looking at the ultrasound between women presenting with decreased fetal movement and receiving an ultrasound within 48 hours versus gestation match controls who had ultrasound for other reasons in the third trimester. So they kind of, I think the other retrospective studies didn't look at whether or not ultrasounds or not. But they found no difference in the abnormal ultrasound findings between the decreased fetal movement group and the controls. It was 20.2 versus 21.3%. They calculated out the number needed to treat to detect one case of SJ, and it was 48. So it's needing to scan 48 women with decreased fetal movement, identify a new case of growth restriction. However, abnormal ultrasound finding percentages were higher in those in the final scan before birth in women with multiple decreased fetal movement restrictions. Again, no clinical significant difference in clinical outcomes between two cohorts. There was, I think, one stillbirth in the decreased fetal movement, but that occurred 8 weeks after presentation that they had normal ultrasound findings. So
but just so I'm clear on this number, so when they say so 20% abnormal ultrasound finding, what does that mean? Growth restriction?
So UA Doppler, MCA Doppler, cerebrospinal ratio. Yeah.
I mean, that's a high 20% of if 1 in 5 times,
that's very high.
5 times you identify something that would maybe not lead to delivery, but additional follow-up. That's not small to me.
They're also saying they're finding that in controls.
But the controls are people, right, because they had meaning, so the controls are like hypertension.
Had other reasons. Oh, sorry, I missed that.
So
they had reasons.
What this tells me is that the rate of identifying an abnormality is the same as the rate of identifying an abnormality for serial ultrasound with chronic hypertension, which is what we do. I think if it was 10% versus 20%, then you say, okay, we do routine screening and 20% of the time we identify something. This is lower, so it's not meeting our threshold for needing routine screening. This is pretty similar, meaning people who have an indication for an ultrasound, 20% of the time we found something. People who don't have an indication, 20% we found something. So maybe decreased fetal movement should be an indication because the rate of an abnormality is the same as these other common reasons for doing the scan.
And I'm so sorry. So you just mentioned chronic hypertension, but remember, sometimes this happens on our, just an AMA patient who just had one ultrasound at 32 weeks and now she's 38 weeks, or a patient who's probably have obesity less than 35, and this one only have one ultrasound at 32 weeks and now I'm 6 weeks later. Right. So this is not someone who had, a serial ultrasound. So.
No, I was saying that it's comparable to someone who's getting serial ultrasounds.
Oh, got it. Yeah, but yeah, absolutely. Yeah.
I mean, when I am thinking about right, they looked at all these markers for decreased movement. So whereas like if you're just doing a routine growth ultrasound, unless they're FGR, wouldn't really do UA, Doppler, and
it would just be the last two, the EFW
Yeah.
and MVP.
Since it's a composite outcome, I would have to like look into the
Yeah,
details
if they
about, like,
reported the individual.
Yeah. I can look more closely into that, but
I'm just curious also, the study by Higgins, which country was that to? For later, maybe not now.
I can,
Yeah. And I can tell you at the end why I think so. Okay.
Better finish, yeah. You have more data?
Yeah.
There's only the only two other studies were more just practical studies about teaching pregnant women about counting fetal movements and implementation of something standardized rather than like specifically looking at ultrasound or FGR. But for example, this RCT by Sostad et al. Randomized patients to like count fetal movements daily versus just routine care, and they found like FGR fetuses were more often identified in the intervention group than the control group, which is interesting. And then this other study by Debate et al. Looked at a QI intervention before and after like implementation of like standardized protocols for how to manage decreased movement. And like I mentioned, they found a decrease in stillbirths and an increase in FGR detection rate. Again, that was a QI study.
This is important. This is the first time I see stillbirth though here, like spelled out in the objective of the study.
Yeah.
Which is really like many of the prior studies, I want a primary outcome to be a stillbirth for me. I'm okay missing an SGA who's gonna survive.
Right.
Okay, but I'm not okay missing a stillbirth, basically.
Right,
So
right.
Yeah. Thank you, Eileen.
Yeah, I didn't know the process for what writing a blurb would look like, but I was just like, okay, I can write whatever, summarize this, and we can discuss like whether or not it would be useful to recommend or, counsel patients about, ultrasound or, yeah.
I think I like certainly for persistent decreased fetal movement, I think that makes sense. I don't think that we need to do an emergency add-on ultrasound for everyone that reports decreased fetal movement, comes into our NST room, feels the baby move, sees the baby move, and then goes home. Or like a 27-weeker who's not used, there's a lot of decreased fetal movement that's like immediately subsequently reassuring.
Yeah.
I think for the ones that aren't immediately subsequently reassuring, then it certainly makes sense. Getting like 9+ weeks with decreased movement should be
I know, but they don't deliver them. That's the issue. There was a 41-weeker when I was on service Subsha with decreased fetal movements, and they were gonna send her out, and then they kept her only because she had the high blood pressure. So I hope you guys understand where we're coming from. My recommendation would be a decreased fetal movement after 32 weeks. If an ultrasound has not been done in the last 4 weeks, like we really need to add a fetal weight for her. I cannot tell you how many I have diagnosed same day with FGR and send them to the hospital for delivery instead of keeping them pregnant. Most likely they will stay probably okay, alive, but then we may also end up with a stillbirth. I never want to say, oh, let's complain twice to triage on decreased fetal movements before I'm gonna do a fetal weight for you. I don't think this is an okay standard of care.
What do you think though for timeline of getting, just because we have 60+ scans a day.
Yeah, and we don't have.
Is this something like that you think needs to happen immediately or schedule in the next week?
We've always been doing this, Upsha. Like, the NST nurses have always instructed them for every decreased fetal movements, we should add a fetal weight. So it really depends. I look at the patient, if she's someone who have multiple risk factors for stillbirth, then I would do it the same day. If she is someone who doesn't, then maybe we can delay it. And honestly, many patients may have had a fetal weight the last 4 weeks, but some of them may have not had a fetal weight. So I really think we have to be decisive for this and just say decreased fetal movements need fetal evaluation. The other thing we have to remember is unfortunately, I don't think everybody is measuring a height of fundus. So there was a patient that I remember, she was a healthcare provider and the baby was FGR. And she herself told me they never measured my height of fundus. So there are certain things, care can never be perfect, but I think with the decreased fetal movement, we can save basically babies. And I think unless you tell me a stillbirth is a primary objective for a study which will require a huge number of patients, it's difficult for me to accept.
Well, the difficulty is, there's a very small percentage of patients that we see in NST with decreased fetal movement. There are a lot of patients that come into triage for decreased fetal movement. And, right, and.
Because usually they come, maybe
yeah, exactly. By the time they get there, the baby's moving, they do an NST.
And then it can be done. I think it can be individualized and then we can add them on. And so basically this is not new. So we get the messages all the time. She was seen in triage, we're adding her on for a fetal weight. So what I'm trying to say, this is already being done. We're just making it formalized so that some of the providers.
Who's doing it? Because I haven't really seen this actually.
But it depends if it's persistent or not. If it's like,
no, yeah, I haven't
that's
seen
the difference.
In ultrasound, people getting growth because they had decreased fetal movement once.
Yeah, me either.
Oh,
And I signed off I remember last week I signed off on an NST for someone with decreased fetal movement because I always review the chart when I see that. And
yeah,
there was not a growth, but the baby, basically she came to NST and felt the baby was moving and had a normal NST and MVP. And
I think it has to be persistent.
Let's go back to
let's
go back, because at the end, the important thing is what we put in this thing. So therefore, we recommend consideration for growth ultrasound if no growth ultrasound within 4 weeks. That's the first thing, right? We put that here.
Within 4 weeks.
If no recent.
No, within 1 week. No, you need to do.
Growth ultrasound if no growth ultrasound within 4 weeks. You know what I mean? Yeah.
Yeah.
And then below where you have here, we could say growth ultrasound within, 72 hours. What do you guys want to see? And then maybe same day for persistent.
I think 1 week is okay if the NST is.
Week.
Yeah.
And
Probably define persistent, so if the.
and sooner.
Are equal to says it.
Like two.
I would take persistent off.
We say one, where they have an ST performed, they're still not.
No. We shouldn't have persistent there, please. They're going to extrapolate it. Persistent headache, they're giving them 6 medications before they deliver someone at 37 weeks for preeclampsia. I wouldn't even say you're kind because, I'm not going to follow up on this patient or you. So I'm not going to say a patient, okay, I'm going to wait for you to come back for decreased fetal movements. I think
guess what might happen though is a patient comes in and says, yeah, yesterday I wasn't feeling the baby move so much. And today I feel more normal movement.
And that's fine. Then she doesn't
that
need.
Patient would need a growth ultrasound though if we don't.
No, she's having normal movements now. I'm okay with that. But probably you can do an NST for her. But I think when a patient presents with that complaint, this is that I have to take seriously. But certainly that patient you mentioned, Sophie, if she has multiple risk factors, then we should do the fetal weight.
But I guess if
that's what she would already
be getting ultrasounds.
Then that's fine. Yeah.
Unless I guess maybe she only had one risk factor, what's multiple, AMA.
Well, AMA and
VM,
obesity is just a one time.
So she's AMA, she's now 36 weeks, right? And she has an episode of fetal movement. She already had a 32-week ultrasound that was normal. So that would be the patient that we would recommend getting added on growth ultrasound between 36 and 37.
Sure. Yeah.
That
I think I listen to the patients too. If someone tells you I haven't felt my baby move all day, you understand me? So
No, I understand what you're saying, Huda, and you make sort of discriminatory judgments. What I'm talking about is there are a lot of patients that come into triage with
Yeah.
various degrees of decreased fetal movement, some of it which is not actually decreased fetal movement. But there's such a low threshold for sending for an NST, so they go with an NST. And I think it's important to consider, are we just going to say every patient in triage who presents for a complaint of decreased fetal movement should have a growth within a week?
Can I just, if we're trying to mitigate the risk of stillbirth, aren't we doing that with like modified BPP though, like with the NST and an AFI? Like, do you know
it's
what I
only
mean?
good for 3
Yeah,
days.
that's only for that
Are
time.
but if we're,
That just says current fetal well-being. It doesn't
Yeah.
give the risk of.
are we adding value with sound within a week?
I think unless
FGR.
It's to detect
Right.
SGA.
What I'm saying was like the person. So.
and what you have to remember also, many of these patients,
SGA, like near term.
You mean like should they just have weekly NSTs instead?
Right, like is that?
I guess it's also like, is the stillbirth in the setting of fetal birth restriction or?
Not always.
Not always, yeah, but.
we never know. It could be absolutely like a genetic disorder that's undiagnosed, but then it's a stillbirth, right? So I think the other thing is, I don't take it lightly when the patient has one medical risk factors like AMA, but you know what? I ask her, when are you planning delivery? She tells me, oh, I'm going to stay pregnant to after 41 weeks. So I get concerned with an episode of decreased fetal movement at 38 weeks, and she's going to be pregnant for 3 more weeks, and I only did the fetal weight on her at 32 weeks. To be honest with you, I also look at the last fetal weight. If she was 20% or less than 25%, these are the patients that typically come back with having a small size baby. So, but who's going to be doing this extensive review for every patient's chart? You understand me? That is why I think if we can just put one consistent thing, a ghost ultrasound within a week, I think that's I think that's reasonable. And then we can see.
Yeah, let's concentrate on that third bullet just to bring it to a
Yes.
conclusion. So are people okay with growth ultrasound
within 1 week?
1 week?
With no caveats then, right?
But
This is every.
we're truly gonna say everybody, even if they had
And maybe
hours of decreased fetal movement on a Tuesday and now it's Friday and they're like, yeah, Tuesday the baby was moving less, but now things are fine. You still want her to get a growth in a week? I'm asking.
what do you think?
No, I wouldn't. Not if she's got normal movement now.
That's like a patient where I feel like you could argue more for the NST. Like, I don't know, because then also if it's persistent and you say you have a normal growth, but say the patient's still not feeling like normal movement, what are you going to do to reassure yourself? Then
Well, I think that's bullet
to
4.
the serial NSTs.
Right, serial NSTs.
Exactly. I think I am on Whitney's side. I think I would say universally we'll just do growth ultrasound within 1 week when the patient presents with decreased fetal movements. Do you understand me? Her presentation is that. Whether she
decreased.
yeah, when the patient presents with decreased fetal movement.
And then they have an NST, and at the NST, they feel movement.
Right. And the ultrasound unit.
Doesn't matter.
So if they're not feeling movement, we don't send them home.
Right.
But
I
then
think
you
that the
will
data
also-
we looked at, the association is, they had a history of decreased fetal movement and then they had an increased risk of SGA. I mean, that's how I read it, you know what I mean? I see your concern.
Yeah,
I
just-
think it's hard to.
I think if they come for an NST for decreased fetal movement,
Could it be
like if you're sending them for an NST for decreased fetal movement, you should also.
Or downstairs.
Yeah, whether it's triage or downstairs. If you decided they don't need an NST, then they don't need a growth.
I think that's reasonable.
Yeah.
So everyone
then-
should get an NST and a growth as soon as able.
The NST should be same day.
Yeah.
Right. And the growth should be within a week.
Same day, great. Growth
Yep.
ultrasound within a week.
I would amend bullet 4 to say
Don't
like,
say NST same day.
oh,
Well, because if someone
24
reports
hours.
decreased fetal movement when they're 37 weeks, I'm not gonna say, oh, we have a spot at 4 p.m.
yeah.
Right, they should come in, be evaluated
But they should also go to triage if they're having decreased fetal movement at times.
Right, exactly. So I would say, I would say we recommend for patients who present for NST for decreased fetal movement that they get a growth ultrasound.
Do you just want to take NST out?
Right, they're already getting an NST, right? If you've decided that this patient needs an NST because of decreased fetal movement, you should also go to growth.
Right, but I just but we need to put NST somewhere on here, right? Or are we just talking?
She's putting it there.
No, but
Okay, got
like
it.
you've
Okay.
already made the decision that you're
Understood.
doing an NST. You can say entry on here.
Yeah.
Yeah.
Gotcha.
Can we go,
You
can we
don't
go
wanna
to
make a name. Got it.
Yeah.
bullet 2? Can we take especially with additional risk factors? Because
Yeah.
how we're gonna divide them?
Yeah,
Great.
there you go.
Thank you. Because your AMA
We
is
can say would both surveillance, like.
It just says the NSTs, serial NSTs, NSTs.
okay, and here we need Dr.
NST
Emily
slash
Oliver.
AFI,
Mhm.
NST slash AFI for
Yeah.
ongoing decreased fetal movement or persistent decreased fetal movement.
Persistent or recurrent.
I would probably do twice a week, to be honest, so that yeah. And I wouldn't say weekly or bi-weekly NSTs for persistent or recurrent decreased fetal movements. Maybe consider
Regular.
Weekly or twice weekly.
Yeah.
Just say serial. Serial.
I love it. Yeah.
Would you also consider umbilical artery Doppler? I don't know.
We only do that.
If baby is small, we would do it.
Consider IOL if term.
Oh, no.
Recommend IOL, or do we want to put that in there, guys?
Yeah.
Recommend IOL.
Good.
Yeah.
Yeah, my 41 weeker was gonna be the shot.
IOL if 90 days or beyond. Yeah. I think
I
you're
want
good.
to make sure Dr. Oliver agrees.
I know, I would have been, but I would.
Yeah, I know.
Good.
Emily, do you agree on 39 weeks delivery if a
Yes,
patient
of course.
presents? How
Yeah,
about
but
30
I
but
think
how
you
about
can
38 weeks?
Months earlier.
I think you can consider before, you can individualize
Yeah,
it.
I honestly, if
Like
they're.
if someone has said I'm 38 and 0 or 37 and 0 and I suddenly have decreased fetal movement over days and it's not getting better, I think it's really hard to be like, oh, we'll do
Sure.
NSTs.
I totally
I don't
agree.
know.
Like, I think we're gonna have I think that many of us in this room agree with what we're saying. I think it might be more difficult to make it a blanket statement, but I think Eileen's consider and discuss with the patient and the provider who is admitting the patient is appropriate.
I think consider allows people to offer it.
And use their.
Yes, exactly.
Their judgment, yeah.
And I think it's also a decision with the patient, like
100%.
people that have had stillbirths, they say over and over, nobody told me about the movement. I felt less movement, like they don't even report it. So,
and isn't it the most common presenting symptom, Emily, for stillbirth?
I think so. Yeah.
Emily is our stillbirth expert, and I'm glad you were here today with us on this.
Yeah.
Can we add the word consider IOL for item 4?
Oh, it is. Yeah, it is.
Can we say consider induction of labor if 37, just so that we're.
IOL. Oh, add IOL. Yeah.
Okay, thank you. Great. Oh my God. I'm so happy, guys. Thank you so much for all of this amazing work.
Direction of labor.
Yep. Great.
Great job, Eileen. Thank you so much.
Yeah, this is not easy. Well done.
Yeah.
Good input.
Seems like we need
That needs
we
to
need to
be.
put all of those trials together in a nice systematic review.
I'm bringing it down. It's systematic review.
Expert opinion on my desk this afternoon.
This is ready to
No,
edit
this
it.
is true. It's so.
You've done the work on it. You've already done all the work.
Yeah.
Systematic review is going to. So this needs to be, are you gonna present it to guideline meeting or like it needs to be so that the triage NPs need to know basically?
Yeah, we should present it at the guideline meeting.
And I think they do a good job of messaging for follow-up, whatever is needed. I think they do a good job of that. They just need to know.
Is this like a epic blurb? Like how?
I think.
Yeah, that's what I'm wondering.
I think this should be an AS blurb because it's a setting where we see DQ.
Yeah.
But we won't see that. No.
See them. Plus, it's
I
making
think the
guidance.
majority of these patients are triage patients that we would
I
never
guess
otherwise see.
So NST blur?
They are reading NST or like looking at NSTs for decreased.
So I think it's an NST blur.
NST blur.
It doesn't make sense to have it.
What is
But,
NST?
yeah,
Like an epic.
The nurses can add it.
It's an epic blurb that they can put in the NST note or they can put in their
Yeah,
training.
I don't know, epic, you're right, so epic, epic blur, but I'm just saying, like, we need, like, the NPs and triage, like, and the residents and everyone needs to know about it, which is why
Guideline meeting.
it should be presented at guideline meeting.
Totally.
Otherwise, people won't.
Won't
know
do
that-
anything.
Right, they won't know that.
When did this happen? And
Yeah.
Go ahead, Sophie.
Sorry, practically speaking, I know we are kind of removed from like NSTs, like, you know, when Judy comes in with a strip, usually we don't get that unless. And that, correct me if I'm wrong, not every NST strip, unless it's concerning and needs further action, gets looked at by the attendant. who's covering it. So. The point person.
Well, we look at them, just not in real time. I mean, I look at all of them, but
Yeah, of
it's not in real time.
Sorry, I meant like.
Yeah.
Like they could leave.
Correct.
the team.
And usually do.
So then the point person for counseling, if the indication is decreased fetal movement, is not us.
Right, that's why I'm saying it needs to be reviewed in guideline meeting,
Yeah, it's-
because
and
we
then-
don't see them.
Yeah.
It's
so then they have to
NPs,
go
it's
through all of the
midwives, yeah.
The generalists.
Generalists who see them in the office, yeah.
And it's like mostly our NST nurses.
No, I think by the time they get to the NST.
It's some of them is the NST, I think
The
the nurses.
providers should already have.
It's
had this-
easiest for us to educate our nurses, but again, they see a very small percentage of decreased fetal movement patients. It's the rest of the practice.
And really the ones that come to NST are typically the patients that are like in
Clearly.
Yeah, that's the only
Like,
one.
let's have an add-on. Majority just go straight to the hospital.
Right.
So this is really just to make the triage teams that labor and delivery teams.
Yeah, which is, and he's and residents,
Right.
but sometimes there isn't an NP. So it really just email Jess Abrams.
I also wanted to do greater than 20 weeks.
Yeah,
Yes,
greater than
right.
20 weeks, yeah, exactly.
We'll just email her with the.
Yeah, just say, this
They'll
is a,
include your data because
Yeah.
some of them will want to look at the data.
yeah, so you include, so, and then you can say this is based on the summary of evidence below, and then you have that and your references like you have. So I would put that, basically just put your blurb at the top.
Okay.
And then it's also, then it'll be added, well, it'll be disseminated, so it'll be at the guideline meeting, but also if anyone wants to look at that, they can look at it, the references also.
Very well done. I'll steal 2 minutes. I'll tell you a story. I think Rupia may have heard this story, but I think none of you have heard the story. So regarding, and it's somewhat related, so pardon me if it's not completely related. So regarding, fetal movement and stuff, there's all this fetal movement counting, do you do it, you don't, which leads me to kind of what we've been discussing the last few minutes. And so to make the long story short, in 2020, we published a meta-analysis in the Green Journal about, should you do fetal movement counting or not? And the conclusion was that there was an 8% decrease in stillbirth, but it was not significant despite tens of thousands of people, in big randomized studies. And, we sent it in saying, 8% may not be statistically significant. I think the P went, the risk went to 1.00. But basically the Green Journal, they wouldn't publish it saying like this may work. They just say, this doesn't work. And 8% decrease, but not significant. So we got a letter to the editor saying, but look, 8% is clinically significant. Well, it's not such a, so I was like, yeah. And so we wrote a letter saying, and actually said it was the editor and the reviewers who felt very strongly that 8%, did not count, so to speak. Was not statistically significant. We took it out, but our original submission was that 8% was clinically significant. So thank you very much. And then the Green Journal, this is the first time and only time it has happened, I think, published another thing after our thing, saying, the editors want to say that this is all true, and we still stand by the fact that, the 8% is just not significant, so should not count. And I was just wondering that because this stuff is difficult. You reviewed a lot of literature, we all looked at it, and you can interpret it differently. And, do you live and die by the statistics or not? And it's complex, it's what we do. But it was a beautiful team effort today, and thank you for leading the Anyway, elective, are we done with blurbs and stuff, right? This was the highlights. Maybe you want to do your thing.
Can I just say one
Yeah.
thing, just to piggyback on that, just to reinforce, like when you're reading papers, statistical significance doesn't mean something is right or wrong, right? That's not like a truth. Means that depending on what p-value you pick, there is a 95% certainty you can say that this is the risk of something happening or not happening. And that the likelihood of that happening or not happening is between 80% and or nothing, or 20% and 0, right? If you're going from a relative risk of 0.8 to 1.0, that means the likelihood this will reduce the risk is anywhere between 0 and 20%. So it could be 0%, it could also be 20%, right? And so, or it could have been like 1 to 20%. And how different is that for you as a clinician, right? So a lot of, especially like if you look, you're doing like New England Journal or Lancet, or Green Journal, or I'm sure the Gray also, you a priori decide what statistical significance is to you that will impact your desire for clinical change. And you decide that in advance, so you're not biased by what you see, and then you present your data as such. And they will not let you say that something's significant clinically when it's not statistically significant. No editor of those journals would let you do that. But when you're writing your paper, again, when you're planning your project, you decide what that threshold is. And when you're reading a paper, you can decide what that threshold is, right? Like the authors have selected X threshold. For me personally, if there is a 90% likelihood that this will reduce the risk of stillbirth, that's good enough for me. And you know, if you change your p-value to 0.10 and not 0.05, then that would be significant, right? And so I just want you to realize that that's why it's so important that you read papers and not just take the conclusion at the end, because there's nothing about numbers and statistics that makes something true or false. It's just the likelihood of an answer.
Well said.
My name is Andrea Sanchez, I'm one of the visiting residents for this month. I'm going to be talking today about hepatic adenomas in pregnancy. We're going to be talking a little bit about diagnosis, management, and outcome. I'm going to start with a case. We have a 23-year-old D2P1001 that was transferred from an outside hospital at 23 and 6 in the setting of a liver mass suspected to be a hepatic adenoma. This might sound familiar. This was a patient that we had for 2 weeks here. On looking into her outside records, we were able to find an abdominal ultrasound that was done in 2022 that showed a normal liver. And after that, there was no presentation to care. Then she presented to the ED. This was in Rhode Island with abdominal pain, nausea, and decreased appetite. This was in June 2025. She was at this time 6 weeks and 2 days pregnant. On that admission, she was seen by the ED and not by an OB or OB provider, and she did not go to labor hall. In the setting of her workup, she had a right upper quadrant ultrasound that they described that she had a mass in the left side of the liver that was measuring around 7 by 4 by 7, and described that this might be a mass or just a prominent caudate lobe of the liver, but they need further characterization by MRI. When I looked into the documentation from the ED providers, it says that, yes, they say that the mass was present, but because she's pregnant, they recommend an MRI after she delivers to not expose the pregnancy to the contrast, and that she should get just after pregnancy care for this mass. When you talk to the patient,
Reminds me of the
Increased blood flow won't do anything. MED haven't even reached 30.
When we talked to the patient said that they noted a coin-sized mass, very small, that nothing needed to be done. 7 centimeters, a little bit bigger than a coin. So the patient was not even aware that that was that size. So she was transferred here. We quickly were able to do a very interdisciplinary approach. We consulted transplant surgery and intervention radiology, which they recommended further imaging for her. She was able to get an MRI, and you can see this is a very interesting picture right here. This is her. Again, you can see here the liver over here, and you can see this large mass all over this area here, and you can see here how big the mass is, and this is the pregnancy. On MRI, the mass was found to be 9 by 6 centimeters, and it showed a central scar, which you describe as this coming into here. She also had an ultrasound with contrast that showed, so this is the liver right here, normal parenchymal tissue of the liver, and then you can see this large mass in this area. They described it as 8 by 5, and by the images, it seemed to be non-malignant, and it has the characteristics of a hepatic adenoma. After imaging,
You can go back again.
this is the normal parenchyma over here, and then over here, this would be the mass. And this is the MRI. It should be over.
Do any like imaging with color flow?
How does that? So they did an MRI with and without contrast, and they actually said that the ultrasound with contrast was going to be a little bit better to be able to see it, but I didn't see anything with color flow.
You did an MRI with him?
Yeah.
We did. No, we
Oh.
did one in the inpatient unit. When she was here, we did one with color flow and there was no vascularity in it.
Okay, thank you.
For the ultrasound with contrast was very interesting. It was a little bit of hard to get her to this. There's minimal studies in the United States, a lot of studies, and this is normally done in Europe about ultrasound contrast. It's like a bubble study for the heart, but you inject in the IV. It's kind of like a bubble. In the outside, you have liquids, and the inside, it has kind of like air. It goes into the circulation, and it responds to the ultrasound waves and creates a window. It's out of her body in 4 minutes, and it goes by CO2 when she just like breathes it out. It's something different that can be used, especially for liver cancer, especially in Europe. After she got the imaging and interdisciplinary discussion, the patient underwent an iron embolization here. And 1 week later, she had imaging performed, and this is the imaging that she had. She had a CTA. To be fair, they recommended first an MRI, repeat MRI, but she had an episode of acute pain, and we thought that she was having maybe some kind of bleeding. So that's why we decided for a CTA. But here in this CTA, you can see liver over here, and you can see the mass. For the mass, they describe it that now it's bigger. It's 11.3 by 6 by 8. When we talked to IR, they said that this were changes that were expected after the IR procedure, maybe some edema in the area or just because of the dying area. That's what they described, and they say that for the CT scan, you can see that the majority of the mass was avascular, although they do say that they were able to go to one of the vessels, but one of the vessels from the kind of like the stomach going to the liver, it's still getting a little bit of blood flow to the mass. And you can see over here that big mass here in comparison with the pregnancy. Yeah. Again, this is just kind of like to introduce a little bit about the topic, because this was at least a very new thing for me, and it was a lot of literature review to see with imaging it's the best, what is the management in pregnancy, and to make sure this patient was receiving the best care possible. So for this presentation, I'm going to go over the definitions, the epidemiology, the management recommendations, and then go over the whole pregnancy course and what's out there in terms of literature. When we talk about hepatic adenoma, that's a benign, what they call a benign tumor of the liver. It's usually unencapsulated, so it's just attached to the liver and it's continuous in some parts. Usually when you are able to see it under the microscope, it has normal appearing hepatocytes. There's nothing malignant to the adenoma, and it lacks portal tracts and bile ducts elements. So again, it's completely liver kind of like tissue. Something very important that's important to this case and to our patients, it responds to steroid hormones because the liver has a lot of steroid receptors, including estrogen receptors. But when we talk about the prevalence, it's rare. Usually in patients without any OCP use, it's like 1 to 1.3 per million. So again, very rare. When we talk about OCP users, and this is more kind of like the board question, this patient with OCPs with liver mass, what does she have? Is usually an adenoma because it increases to 30 to 40 per million. So again, risk factors and something that we have to assess in our history would be the OCP use. Usually, it's are going to be patients that are women in their reproductive age, most likely because of the correlation with the use of OCP. When we talk about the primary risk factors, again, the first thing that we have to ask the patient if any use of OCPs or any use of estrogen. They say that there's actually a 500-fold increase if the patient has 85 months of use. So and the papers are cited here, they do say that there's a dose response relationship between estrogen and the presence of the hepatoma, not necessarily the size, just the presence. When we talk about other risk factors, they said that usually when patients use anabolic steroid use, usually in male patients, this can be seen, and it's kind of like this small amount of cases are in male patients, usually when they just, because usually, and when they talked about this, it's people that are going to the gym and are just injecting anabolic steroids, and then they present with this liver mass. And some genetic, like familial adenomatosis polyposis, and then MODY, which is just kind of like late diabetes. To talk about the hormonal changes that I was talking a little bit before, as the liver has estrogen receptors, and in pregnancy itself, there has been reports that the estrogen increases since the first trimester to the third trimester, and in this paper they mentioned a 9-fold increase in estrogen, and a dose-dependent relationship between again the estrogen and the adenoma kind of growth. And this you cannot see here too well, but this is over here weeks. It starts kind of like 12 weeks all the way to 37 weeks. And this over here, this red line would be estrogen levels, and you can see how it kind of like comes up. This is in like prime patients, and this is in multi patients. So you can see that the estrogen increases, and that's important for patients that have the adenoma. And why pregnancy can be a risk factor is other than because of the amount of estrogen that increases during the pregnancy, just because of the changes that we all know that happen in pregnancy, that increase in blood flow, that increase in the cardiac output, and how that just compression of the IVC and everything increases the hepatic congestion, and the size actually of the liver can increase during pregnancy. So to talk about the possible complications of hepatic adenomas, the two that we are more concerned about is hemorrhage and malignant transformation. So when you have an adenoma, regardless of size, the lifetime risk of hemorrhage is 21 to 40%, which is pretty high. But of those cases, only less than 5% would be for small adenomas, which is 5 centimeters. So that's why the cutoff of 5 centimeters is used. Because that's what has been shown on previous papers and research to be the cutoff that changes that hemorrhage risk. So for risk factors, if the patient is, again, on OCP use, or if there's any inflammatory subtype, and we're going to talk about that in a little bit, there's this increase in hemorrhage. Hemorrhage can show in multiple ways. It can be confined, and it can be like a parenchymal hemorrhage, or just a hematoma that presents, or it can just be frank bleeding all the way to hemoperineum, kind of like putting the life of the patient in danger. When we talk about the malignant transformation, the overall risk is 4 to 8%. It's important that some types of adenomas are a higher risk to have a malignant transformation, but the adenoma itself is not a premalignant lesion. I wanted to include a little bit of info about histology classifications and how we are able to identify and see it during the imaging. When we look at histology classifications, there's a French group that actually specializes on hepatic adenomas and their histology, and they created different groups of or subcategories of the hepatic adenomas that are defined by genetics. So depending on the expression of the genetics, they kind of like are able to identify them. It's important that for this, you need a biopsy of the lesion, or you just need the lesion to be removed. In pregnancy, biopsy is not recommended because of the high risk of bleeding. When we are able to see over here, and this is just a very quick overview, this over here, it's almost the HNF1. It's almost always in patients, in women, and has a lot of steatosis, so a lot of fat contact on the mass. Very low malignant potential, usually is the most common. Usually 35% of patients have this type. When we talk about this other one over here, this one is more common in men and has the highest risk of malignancy to usually 4 to 8%. And then we have the inflammatory, which was the one that I was talking about before. This goes into the JAK-STAT3 pathway, and usually it comes with a very elevated CRP, and it comes more of an infectious kind of like presentation, and it can present with cholestasis too. So again, different types, we need a biopsy. This is just an overview to know exactly how they classify it, at least histologically. When we talk about gross pathology, and I just wanted to take, because usually we see it in imaging, but we don't see the gross pathology. The majority of adenomas are going to be solitary, and they are going to be well circumscribed. Again, they're going to be unencapsulated, or are going to have a very ill-defined pseudocapsule, but it's not a full capsule. Usually it has a different color from the surrounding parenchyma. So you can see over here too, a lot of vascularity in comparison with the surrounding tissue. This figure D, this patient had a BMI of more than 40 and was on oral contraceptive for 18 years. She had a hepatectomy, and that's why we have the specimen. And finally, the diagnosis came back as inflammatory hepatic adenoma. This second one, she was oral contraceptive for 31 years. And she was having nausea and vomiting, and then it was removed because she was really symptomatic, and was not eating because of the pressure and the pain that she was having from the mass. And then this other one, you can see that it started to hemorrhage. This was a little bit more contained. This patient was not on any contraceptive at all. So if we look back at the statistics, this is rare, 1 in 1 to 4 in a million, which is pretty rare. And again, under the microscope, just kind of like a quick thing, you can see that it's very well defined. You can see this lots of fat globules, and then this over here is just normal liver parenchyma. When we talk about the different imaging modalities that we can use to see the hepatic hematomas, adenomas, I'm sorry, we usually start with an ultrasound, and this is how it's seen. It's a solitary, very well demarcated mass. How it's looked, it's a little bit variable. It can be hypoechoic or it can be hyperechoic. It also depends if it has like a central fibrous or central fat. It will look a little bit different. But once the radiologists see this, they usually ask for further imaging, and normally they ask for MRI to further characterize it. And this is how it looks on the MRI. So this is the preferred diagnostic modality. You can see this is normal liver parenchyma, and you can see this very large mass. Usually they recommend it to be with contrast, because they can differentiate the subtypes by imaging, but the final diagnosis would only be by biopsy. And then this is just the CT with contrast. This is, if you cannot do the MRI for whatever reason, this is what you would do. You can see that here it's harder to characterize the mass, but you can see that there's something distinct from the liver parenchyma. Now, we know we have identified that our patient has an hepatic adenoma, then what do we do? So I kind of like went over the management pre-pregnancy, pregnancy, and postpartum to kind of like have a little bit of more sense in terms of the chronological order of this. So pre-pregnancy, usually the medical management for any patient that comes in is discontinuation of OCPs if she is on any. So nothing that has estrogen can be given to this patient. Usually they would be observed for 6 months after they stop the OCPs, and observation would be appropriate if one, the mass shrinked in size, if the size of the mass is less than 5 centimeters, and if the patient is completely asymptomatic, so that the patient can have observation if those things are met. Now, what if those things are not met? Then intervention would be recommended. So if the size is more than 5 centimeters after the 6 months after the OCPs, if there's male sex, they put this here because male sex is associated with liver cancer or transformation. So rare in males, but when it's present, high risk for transformation. If there's any kind of suspicion for bleeding or for rupture, or just fail regression, and it 6 months after the patient stopped the OCPs, the mass is the same. Now, what kind of interventions are they? There are the hepatic resection, the radiofrequency ablation, and the arterial embolization. I'm gonna go over them super quickly just so we can have an idea of what they looked like when transplant surgery and IR were able to, oh, these are the things that we can do. We had like no idea, and we really had to go out of our way to look for it. So this is just for us to have an idea. So when we talk about the hepatic resection, it's a pretty big surgery with a very big and invasive scar. Usually there are surgeries that need multiple surgeons because they try to cut the vasculature to the liver for a few like minutes, and then it's called a Pringle maneuver. They use like a Haney kind of thing. They put it in, worked, and then unclamped it, and then clamped it again, just because they're so bloody. Usually patients get blood transfusions when this happened. So you can see that this in pregnancy is invasive. It can be done. But it's an invasive surgery for patients.
It always makes me memorize, and I told some of you, for liver transplant and liver surgery, you know what the incision is called?
Zany sign.
And that looks pretty much.
Yeah.
Zany sign.
So,
Yeah.
I was able to find, and this is going to the pregnancy, going into a little bit back, I was able to find surgical interventions in pregnancy. They were very, very rare to find on the lit review. Most of patients undergo other procedures that I'm going to describe, but this was a very interesting case that I wanted to share. This was actually published in 2025. This was a patient, that 29-year-old, that G1P0 that presented at 24 weeks with right upper quadrant pain. She was also found to have nausea and vomiting and early satiety. When she underwent workup, and an MRI showed a 17-centimeter hypervascular inflammatory adenoma with necrosis. So very big, more than 5 centimeters is a very high risk of hemorrhage. Again, 17 it's very big. They had a multidisciplinary meeting with MFM, transplant surgery, and IR. And what the final consensus that it was too early to deliver at this time. Patient was 24 weeks. It was too risky to wait for 32 weeks because of the high risk of hemorrhage and rupture. And again, if this rupture, her life is in danger. She can die from this. And the team elected for immediate surgery at 26 weeks. Now, what's interesting is how they did the surgery. So the surgeons wanted to try to preserve as much as possible the blood flow to baby. So they actually did a cable bypass. So they went into her right femoral vein, and then did a bypass all the way to the jugular vein to be able to bypass the liver, but no bypass the baby, which is, again, rare. And this is a case report. This was just out in 2025. The blood loss for the surgery was 500, which was very minimal. Again, the surgeries are pretty bloody, just because there was no flowed to the liver auto at time of surgery. Baby did okay, mom did okay, and she went to have a normal delivery at 38 weeks and 2 days. Again, something very different, but kind of like an option when we have such a big adenoma that it's not going to respond to other management. The other thing that's available is the radiofrequency ablation, and this procedure is inserting a needle into the tumor, and that will deliver some radio waves, and the goal is just to completely destroy the tumor from inside out. A downside to this is that you're never going to have any tissue biopsy to confirm what kind of adenoma the patient had. But usually in patients that cannot get the surgery or for some reason cannot get the IR procedure, this is the best thing that they have. They were talking about maybe patients with CKD or even patients that are not able to be put under general anesthesia, and for some reason this is what they do. Usually it's pretty successful. I try to go out of my way and look for the success because again, maybe it's good for patients that have CKD, but maybe it doesn't work as much. And actually it does. It's pretty high. The success rate is 88 to 97%. So pretty good. What they did said in that study, it's good for adenomas less than 5 centimeters. If you have more than 5 centimeters, it can do something, but probably not going to be clinically significant in terms of hemorrhage risk.
And then that started, then would you just observe, like,
Yeah, serial ultrasounds and observe. Yeah.
But you're saying that the RFA only works for less than 5
Less than
centimeters,
5.
right? So
Yeah.
you could like do RFA or observe.
Yeah, I guess risk versus benefits with the patient, but it's hard if the greatest risk is getting to surgery or going to die there versus dying from the hemorrhage, which is, yeah. And then the last option would be the embolization, and this is what our patient here had. And the goal of this is just go ahead and block the blood supply to the tumor, depriving it and nutrients, and then trying for the adenoma to die, which for this patient, and it's pretty painful. Again, how I think about it is when a fibroid is sign and how patients present something like this, but in the liver. Usually, and what I could find on the papers was that this was usually done for patients that have very large adenomas that we think that they're very vascular. They usually underwent an IR procedure, like sometimes we do for myomectomies, underwent an IR procedure and then later underwent a open resection. But also in pregnancy, it's done when it's small enough that we think it's going to work. And they don't describe what small enough is. There's a couple of just case reports, but there's not a magic number as to when IR is going to work. Usually the tumor is able to be decreased in size, and this was significant to tumors that were around less than 12 centimeters. So again, reduce in size with less vasculature because it's blocked might be, the best thing that we have out there right at this second for our patients. Okay, so now we have this patient comes in, has this history of adenoma, wants to get pregnant, goes to MFM for preconception counseling. What do we say? What data is out there for guiding our management? So the recommendation first is to confirm the diagnosis. If you have a patient that has a liver mass, it can be an adenoma, or it can be something else. So it's important that we get an ultrasound and then we get the MRI, as we know is the best modality. It's very important to rule out the focal neural hyperplasia, and that's another growth that can happen in the liver. It's more fibrous. Doesn't have any hemorrhage risk. So again, very different management, very different impact on the health of the patient. And again, it would be biopsy if the patient doesn't want complete removal. And because the patient is not pregnant, this would be the best time to do a biopsy. And then just refer to hepatology so they can counsel the patient further and give their recommendations. When we talk about our patients about risk stratification, again, we use that magic number of 5 centimeters. If the adenoma is less than 5 centimeters and she's using OCPs, discontinue, wait 6 months, and repeat ultrasound. Hopefully that's a decrease in size. If it decreases in size, then the recommendation is that she can have a pregnancy without any concern, they do say that usually, and again, this is individualized, there's not a specific guideline, but you should follow up with ultrasounds during the day. If the adenoma is more than 5 centimeters, you can observe for 6 months, but the likelihood of regression is less. And if there's no kind of regression, then you have to do any kind of the interventions that we already said and defer pregnancy until we have that either out of the body or less than 5 centimeters. So now the patient is pregnant, already pregnant, comes in with something, we do an ultrasound and she has an adenoma. Important thing, size. If it's a small adenoma, less than 5 centimeters, what the American Association of Liver Disease recommend is an ultrasound in every trimester of the liver to try to assess for size, understanding that it would an increase in size in this third trimester is expected given the pathophysiology of the mass. And then multidisciplinary care with hepatology, cardiology, and the MFM. They also say that it's very important to very closely monitor for growth, but also to talk to the patients about just symptoms that they might experience and symptoms to come into the hospital for. There was a study that was able to find, it was done in 2020. It was a prospective study of 51 pregnancies that had hepatic adenomas of less than 5%. They showed that 22.5% of them showed growth in the pregnancy with a median amount of growth of 14 millimeters. So we're not talking about very exponential, very clinical significant growth, just about a median of 14 millimeters. There were no hemorrhage during the pregnancy of postpartum in this study. One patient did require embolization at 26 weeks because her adenoma was bigger than 5 centimeters at that time, and she did well, normal delivery. And their conclusions was that in the setting of a small adenoma, less than 5 centimeters, the hemorrhage risk is low. So there's no risk to the pregnancy itself. Again, this is just one study, but this is what they concluded. When we talk about large adenomas in pregnancy, and this was the case of our patient, are any adenomas more than 5 centimeters, we need to be on top of this. We need to do serial ultrasounds, and we need to see exactly what's going on in terms of the growth of the adenoma. There are no specific guidelines as to how often you should do it, how often in the third trimester, for example. But they do say that you should do at least every trimester, and in the third trimester, you should be more aware of the size of the adenoma. It's very important that the indications for intervention in pregnancy are the same as outside of pregnancy. So just because she's pregnant, we don't change the management. If there's rupture of active bleeding, if we see there's any signs of hemaperitoneum, if the patient is very symptomatic, like our patient's nausea, vomiting, she was not eating, or if there's any significant growth in the pregnancy, we should go ahead and intervene. There was a study, it's called the Herring Systematic Review. This was done in 2021, where they found 15 hemorrhagic episodes in pregnant patients that had hepatic adenomas. The tumor sizes range from 6.5 to 17 centimeters, so all of them were large adenomas. And they looked at when did the hemorrhage occur to try to assess for risk depending on trimester. Eight of the patients had a hemorrhage during the pregnancy, age of the 15, and 7 of them occurred in the third trimester. 2 of them had them during labor, and this labor was vaginal delivery. It was not a scheduled C-section. They were able to do vaginal delivery. And the 2 cases, they had a vaginal delivery and while they were having pain and they were laboring, and then they had to be brought back to a SAT section. There was a hemaperitoneum found on the section coming from the adenoma. And then 5 of them were postpartum, with 4 of them, or the majority of them, in those first 2 weeks of postpartum. So that helps us a little bit to see that based on this data, third trimester is the highest risk in terms of pregnancy. But we have to be very aware of that postpartum period. Not because she's not pregnant anymore means that her risk comes down significantly in the first 2 weeks postpartum. There was another review in 2004 that reviewed 116 pregnancies with any kind of liver masses, and they included 26 of that had hepatic adenoma. All of them were larger than 6.5 centimeters, so all of them were large. And they found, again, in this paper, a 44% of maternal mortality and a 38% of fetal mortality. It's very important to know that these results are skewed. So these patients came most likely already symptomatic to the hospital, and that's how they were identified to have a liver mass and then an adenoma. But these are pretty high numbers in terms of mortality for mom and for baby. Now, mode of delivery, and that was a question that our team had too. Our team, in terms of this case, we talked to IR and we talked to vascular surgery and trauma surgery, and they said that because the IR procedure was successful, given the imaging, they were okay with the vaginal delivery. When we looked at the literature, there's some studies out there more about case reviews and case reports. Usually for these cases, in terms of historic data, they usually recommend cesarean section because of the fear of Valsalva and the increase of intra-abdominal pressure it can have on the adenoma and the increase in bleeding. But there's now a view a little bit more lenient that says there's not really good data supporting that cesarean section should be done only for the sole reason of the hepatic adenoma. But at the end, it should be an individualized approach. Most likely taking into consideration the size of the mass, if there was able to be something done, and if in our patient she underwent IR, is the mass really low, like shrinking, or is the mass still the same size? So this would be more of an ongoing conversation with the patient and a risk versus benefit discussion. When we talk about mode of delivery, I was able just to find over here, it's the same study than before. Again, 2 patients of the 15, the hemorrhage occurred during labor. But again, when this happened, patient had to be rushed back to the OR for a SAT section, and there was hemoperineum found. So maybe vaginal delivery can be done, knowing that the probability for a SAT section is there, and it would be an emergent situation for mom and for baby. And then this is just to finish postpartum. Again, just because the patient delivered doesn't mean that her risk decreases. We saw in that other study that 5 of the 15 hemorrhages happened within 4 weeks, between 2 weeks of the postpartum period. They say that usually there's estrogen withdrawal in the body because of the pregnancy, and the adenoma can start to degenerate. And if it goes into a vessel, the vessel just goes ahead and bursts just because it's more exposed than before. So what they recommend is just to monitor for the first 2 weeks. Again, they don't explain what monitoring means, but just that it's important to do. And then that ultrasounds can be considered in the postpartum period. And now that the patient will be 6 to 10 weeks postpartum, then she can go ahead and get an intervention in preparation for a next pregnancy if desired by the patient. Contraception, very, very important. I know that sometimes we deliver the patients, we follow them, but we don't see them postpartum. Patients cannot receive any kind of estrogen. They can receive progesterone, but this is something really important to kind of like have in mind. And these patients who have hepatology referral and then transplant surgery versus just more colorectal and hepatology surgery referral, just in case they want follow-up. So again, key takeaways, adenomas are rare, but when they happen, they can be have high mortality for mom and for baby. It's very important to understand the size of the mass because that is going to help us in our next steps and in our management. And for pregnant patients, they can undergo IR procedure or surgery, and this will depend on the hospital and the multidisciplinary team taking care of her. And the references. Any questions?
I mean, thank you. Very comprehensive, reviewing some of the literature, it's pretty scary, to see all those ruptures and some mothers die, some fetuses die. So I think this case was well handled. I'm glad, and as I say many times, I work in a place like this that you can convince different people, radiology, GI, transplant. At the end, everybody was on the same page. And How often is she gonna get ultrasounds, to see if it, it increased? Or MRIs, is there a plan? I know she's following up a well span.
Yeah, so for here, we asked that multiple times and IR just said MRI after the pregnancy.
Okay.
And we asked any more, like, well, how do we know? And they said nothing else to be done. I guess that once she goes to WellSpan, probably she will get another consult and then we'll follow up and see. Per the guidelines, she should get any type of ultrasound just to assess the size, maybe even closer to delivery if the patient desires a vaginal delivery and we're talking about delivery mode. But their recommendation was only MRI after delivery.
This was just IR though, right?
Yeah, IR and transplant.
And transplant.
We consulted GI hepatology and they said they really had nothing else to add to the case, so they didn't add any further recommendation.
She going to have an intervention after delivery or not?
So it depends on how much it shrinks. After delivery, it's supposed to be shrinking because of the withdrawal of the estrogen and with the IR procedure. But I guess that because it was pretty big, she will most likely need something. Probably surgery because she already got the IR.
Great. Let's move to the last run here. The Precious trial.
Hey everyone, good morning. Thank you for giving us this time to talk to you guys. Me and Jordan are going to talk about the Precious trial. Okay, I'll just start talking. So currently we're doing this randomized controlled trial. We're comparing CGMs versus finger sticks in people who are pregnant who have type 2 diabetes. This is our team. Thank you to our mentors, Dr. Kanuja. So yes, a little bit about the background. So we know that type 2 diabetes is rising. 1 out of 10 people do have pre-gestational diabetes, and 90% of that 1 out of 10 people have type 2 diabetes. There's about 40,000 pregnancies per year, and there has been a 27% increase from 2016. So we know that tight glycemic control is key, but however, this poses a high burden on patients. So we expect them to do finger sticks very frequently. We expect them to follow the standard of care where our fasting, I know we do 95, but 90, 1 hour postprandial is less than 140, 2 hours less than 120. So yes, the issue is because it's so difficult to do finger stick monitoring, we were thinking with the new CGMs, we are able to get a closer and I'm not sure about accuracy, but at least in real-time monitoring of what's going on with their blood sugars. And the key issue here is that with the finger sticks, we know that non-adherence is up to 50%. And so briefly with the CGMs, we know that you have a sensor, you have the interstitial space, and then you're connected to your monitor. So the sensor will tell you the amount of glucose in the interstitial space and then send it back to the app. And so you get real-time information every 1 to 2 minutes. And then the main thing is that the CGMs, patients have to come back every 1 to 2 weeks and get them replaced.
Or they can replace them themselves.
Yeah. So the previous studies about diabetes and CGMs, the huge trials, the concept trial, however, this was based on type 1 diabetes, and they were comparing CGMs plus finger sticks versus finger sticks alone. But right now, we know that there isn't that much data for type 2 diabetes because the current studies are either retrospective studies. Retrospective studies. Oh, sorry. Oh my gosh. We can quickly, yeah. The concept trial was showing that there was improved outcomes, specifically in LGA, neonatal hypoglycemia, and NICU admissions. So for type 2 diabetes, the only studies that are currently around are either retrospective studies. This Cetra study was a small RCT
And this Vormilone study was also a retrospective study, but there are currently no RCTs for type 2 diabetes with a large number of people.
I think it's just
yeah, you can keep going. So in summary, these are the key points of what I just talked about. So yeah, the rate of type 2 diabetes is rising. We know that there's a known benefits. There's low adherence for finger sticks. So we want to, and the current studies only show that their tighter control for diabetes improves neonatal and maternal outcomes. And because there's insufficient data for type 2 diabetes, that's why we're doing the PRECIOUS trial. Okay, next we'll talk about the objectives and our hypotheses.
So looking at our objective and aims, the first one is going to compare the adherence to glucose monitoring using CGM versus finger stick for blood glucose monitoring in pregnant patients with type 2 diabetes. And then our secondary aims are going to be to compare neonatal and maternal outcomes using CGM versus the finger stick, as well as for the titration of insulin for pregnant patients. So our hypothesis is going to be that CGM will have an increased adherence compared to finger stick, which is not that surprising if the CGM is going to basically be sitting on the patient's arm all day for 24/7. And for the second aim, we also expect that because there's going to be improved glycemic control because they're going to have better adherence and knowing their blood sugar and can have better titration levels. So the first objective through this pilot study is just looking at the primary outcome of adherence. And we're going to check this or monitor this by with the CGM looking at the number of days having a CGM usage of over 75%, as well as the number of days they started on the CGM compared to when they delivered. And then similarly for finger stick blood glucose, we're going to check how many days they have readings of at least 4 values indicating that they are following with the protocol. And then similarly, number of days from initiation to delivery. And then secondary outcomes are going to be related to mostly like the CGM use or how well they are adhering to the insulin protocol. So look if they're adhering to the protocol, and then also looking at the insulin titrations just to see if we can compare, if their blood sugar is high and they aren't getting increased insulin, we need to know that as like a confounding variable. And then also looking at the patient, if they like using the CGM or if they like using the sticks, and then any adverse effects.
So a quick question about the number greater than 4
Yeah.
values. So like, let's say if someone doesn't eat or like they're checking it because they didn't have a breakfast or lunch, how does that factor in? Like that would affect the numerator, right?
Yeah.
Like, is it like one to one? I don't know.
I mean, like typically patients should be
Right.
in 4 times a day fasting.
Right.
Meals. But
I think originally we had it down as number of finger pricks divided by the day. I changed that to number 4, but like 4 times a day, but that makes more sense to have total number of finger sticks per day. And you can divide that by the number of days.
People are like, oh, it happened.
And it's interesting because there's no like official guidance about how often you should check your blood sugar. It's not 4 times a day necessarily. It's you want to have a goal range of over or under 140 after 1 hour, but it doesn't give a stipulation that you should check X amount of times a day. So it seems common practice is to do 4 a day, when you wake up for fasting and then when you're eating. And then for the that would be the pilot study, and then this would be more of a clinical like a bigger study looking at neonatal outcomes. And we will be looking at all different metrics from like APGAR to birth weight and LGA just listed here, and then also checking the maternal outcomes as well. And we would do a composite score, adding each point up the outcomes. So our study population is going to be patients that have pre-gestational type 2 diabetes seen at health centers or Jefferson Obstetrics and Gynecology Associates. And for the inclusion criteria, we want them to have a type 2 diabetes diagnosis before conception and or prior to 20 weeks. There may be some patients that don't know they have an elevated A1C, and we could pick that up through the early, like their first prenatal visit. Also, to be over 18 years of age, and then we want to make sure that they are getting enrolled in the study before 20 weeks, because it could be confounding with gestational diabetes setting in around the 20-week mark. And then single pregnancy, exclusion type 1 diabetes, excluding gestational diabetes, and then any multifetal gestations or known anomalies.
If somebody is diagnosed with GDM at like 10 weeks of pregnancy and their A1C is normal, they're not eligible, right?
So we're switching.
Oh, okay.
Yes, we're going to change the IRB to.
Okay, so early onset GDM would also be included. Okay, so that's a new.
Because I think that's gonna help us with
Numbers.
patients. Yeah, specifically, we've been having difficulties with numbers right now, but. Okay.
All right, so eventually that will be true.
Yeah.
Okay, so our study design, we have 2 arms. Our control is gonna be the finger sticks and the intervention is the CGMs. Okay, so then we have been combing through all the patients each week to see who might be eligible. And then either me or Jordan will approach them, and Dr. Kadenuja.
So many.
We'll approach them and talk to them about the study. If they're interested, we have a little cubby in the resident room with our randomized envelopes. So we'll bring a consent form, we'll grab a randomized envelope, they'll open it, and then they'll be either randomized to either arm. And then each week we're gonna be tracking their adherence. So we're just gonna follow along in the problem list. We need to create a dot phrase so that we specifically have what data we're looking for. But so far we've only had 2 people that are enrolled.
Or if I feel like I might be taking up too much time, so if we need to talk offline, that's fine. But there's titration adjustments that are stipulated by the protocol, or titration like per clinical care.
Clinical care.
Okay,
Because this is just looking at adherence.
right. So that's what I'm saying. It wasn't, it's not conflicting with like, or it's similar to START in any way.
Not
No.
at any.
Okay, great. So just clinical care and do what you might. And we understand inherently that somebody might be titrating insulin differently for CGMs versus finger sticks, and that is fine. Okay, just making sure.
And then at the end, we're just gonna do patient satisfaction surveys to throughout the Likert scale. But yeah, so this is our timeline. We've just started recruitment. Yeah, 2 people. 70, yes, 35 and 35 on each arm.
Totally
Doable, yeah. But we are struggling with enrollment just because a lot of type 2 diabetics already have a CGM. And they're like, well, if I'm not.
I have approached people about it, and the hardest thing is that
They already have.
yeah.
That's kind of why we're expanding to now this.
Makes
sense,
Addended and
Or they so strongly prefer a CGM and they don't want to be randomized to.
totally.
Yeah.
But we have
CGMs, it's free CGM
Okay.
too. I think that's an important thing to know is that, they receive a grant, so that grant is paying for the CGMs for patients who qualify.
Are CGMs usually covered for type 2 diabetes, like for insurance, and also GDM? I'm just curious. GDM is very difficult to get coverage, but type 2 diabetics are
On
easier
insulin.
if they're on it.
Specifically on insulin, because the standard of practice is to not give patients with type 2 diabetes CGMs if they're not on insulin. So if they're on metformin, if they're on like any kind of like oral med, now the GLP-1s are being used, they will not cover. So unless they have like an A1C or on insulin, then they'll cover. I only learned this very recently.
If you had a pocket, but there is a cost card that makes it $75 a month for the Freestyle Libre.
We have an entire stack of, well, $75 a month is a lot for something.
And that includes
I
like
have to go to an education meeting, sorry.
We have a meeting at 12, so sorry that we're stepping out, but I want to ask a quick question. And you know, you're not in it. So if you go to clinical trials, there are so many randomized trials on CGM in pregnancy. Have you seen if other trials are doing it similarly, or if they're doing it differently, or that kind of thing?
Two retrospective studies and one very small.
I don't know that.
There's not, there's.
Going now.
I'm
going now.
Active trials, but not looking at compliance, completely looking at different things.
But some are looking at outcomes as well.
Some are looking at outcomes, but not at compliance. Stay here and see.
Yeah, I think, you know, one message I want to get to everybody, the nicest thing is actually to get in a hot thing. So don't get, like, you know, before you're finished, you know, 3 more trials may come up on the same issue.
Yeah.
That's a good thing. Because it means that you're doing the right thing, that then you can do a meta-analysis, that is a, you know, an important issue. Because I think, I'm sure there's a multi-center randomized study from Alabama who do the same.
Yeah.
Same thing.
Oh, yeah, I did see that.
Well done. Congrats.
Thank you, everyone.
They come out
Pop's
October.
doing a lot with now with.
The next week.
It's different.
Yes.
Yeah. He's doing something.
Well, I mean, they did officially, but yeah, November 6th. Yeah, yeah.
It's like